مش هنا، يعني الناس فين ولا مش هنا؟ بروفيسور ياسر، مساء الخير. حضرتك ميوتد يا دكتور.
اوكي، بروفيسور مارك مش موجود.
لا، كان موجود بس راح يعمل حاجه وجاي، وجربت معاه البرزنتيشن.
ما فيش مشاكل خالص. اوكي تمام. اوكي
محتاجين حضرتك بقى تفتح كده نجرب كده
طيب اوكي.
على الشاشة ده.
ادي لحضرتك اكسس عشان
اه
اتفضل يا دكتور. ايه ده؟ مين داس على الويبينار؟
شايفاني كده؟
دكتور ياسر, you started the webinar.
يا دي الخيبة. نعمل
People are
نعمل
joining, doctor. People are joining.
keep joining.
Yeah, they are keeping joining. The number is increasing now to 48, 52, 55.
طيب اوكي that's fine. اوكي انت معايا؟
أنا كمان.
كمان انت شايفه البرزنتيشن يا مي؟
Not yet.
كده.
No.
share screen.
Yes.
شايفه كده؟
Yes يا دكتور.
اوكي كده كويس.
Yes.
اوكي that's fine. اوكي بروفيسور مارك مش موجود، محمد مش موجود.
Dr. Muhammad is available. Do you like him to start?
استني شوية، هنبتدي 7 7 و5. اوكي تريسي في اخبار عنها؟
Presentation is I have the presentation.
متسجلة؟
لا, presentation من غير صوت.
من غير صوت.
مم.
ده لتريسي؟
Yes.
طيب اوكي دكتور ابو بكر
I have it
بعت لك.
full and perfect.
اوكي that's fine. سو تريسي كالمعتاد هي المشكلة. طب بعت لها قلت لها ان مفيش صوت ان كيس،
Yes.
وردت عليكي قالت لك ايه؟
No reply.
مم. 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 جيهان معانا؟
ايه يا دكتور مع حضرتك؟
معاكي نمرة تريسي؟
بعت لها اكلمها بعد شوية.
اوكي ماشي. احنا محمد معايا. محمد فين يا جماعة؟
Yes,
انا مش
sir.
شايف.
I'm here. Yes, Dr. Yasser.
محمد.
I'm here. Yeah.
ازيك يا محمد، اخبارك ايه؟
Thank you. Thank you. الحمد sir. الحمد
إيه؟
لله.
طب
That's fine.
دكتور ياسر، معلش سؤال على السريع خارج النص. واحنا بكرة الساعة كام؟
بكرة على الساعة 1 2 بعد الصلاة يعني.
ما هو أنا قلت بعد الصلاة، بس هو عايز ميعاد بالظبط عشان يقدر الراجل يجي.
خليها على الساعة 1 1 ونص كده.
من واحدة ونص. أوكي ماشي.
اوكي
شكرا.
1 ونص 1 ونص 2
واحدة
كده.
ونص. ماشي يا دكتور.
اوكي
ماشي حاضر.
طيب اوكي ماشي. عددنا كام دلوقتي يا مي؟
We are 1900 and increasing.
1900.
99. احنا 99. 102 now, doctor.
اوكي that's fine. استنى شوية بقى، انا مش عارف مارك راح فين، نقول له كلمتين.
موجود يا دكتور. هو
اوكي مفيش مشاكل خالص. اوكي هراجع البرزنتيشن. احنا الساعة كام دلوقتي؟ 7. هندي 5 minutes ونبتدي يا محمد.
تمام يا فندم. حاضر.
نهار اسود طب وبعدين
Hey, did you want me to check my mic?
Hi Tracy, how are you doing?
I'm good. I was staying silent because you were talking and I hadn't got a clue what you were talking about.
No, we're waiting you. But by the way, you have a very nice sweet glasses, by the way.
Oh, the
I
nice
think
big
it's
one.
brown, am I right? Is it
Yeah,
brown?
yeah.
Okay, it's
but
wonderful. It's
try and
wonderful.
make me look more clever because I'm not a professor, so you need to
No,
change
no,
that.
not the glasses, but you are very sweet person. Thank you very much to join us.
No problem. I'm sorry it's all been so chaotic.
No, it's
very
great. It's
busy.
great.
So-
So, but
good evening. مساء الخير دكتور ياسر.
أهلا. Welcome, Professor Nashar. Miss Tracy is with us now.
How are you?
Nashar,
Fine?
Tracy,
Yes.
here is Professor Nashar. However, he's not in Egypt. He is
Oh.
outside Egypt and he's insisting to join us. Thank you very much, Professor Nashar.
Oh, you're welcome, Dr. Yasser. Thanks a lot for kind invitation.
Thank you very much. Thank you. Here is sweet Tracy. Finally,
Yes,
we
welcome,
meet her.
Dr. Tracy.
Hi.
Nice to meet you, Dr. Tracy.
Yes, and yourself, sir.
Okay,
Professor, would you like to start now? Because we have approaching the 200 attendees. Would you like to start?
Okay. That's why we are trying to gather as much as we can to start. Okay. So where is Professor Mark?
Hello, I'm here.
Hi, how are you doing? How are
I
you
didn't
doing,
can
sir?
see. All right, thank you. I'm fine.
Pleasure meeting
Ready
you.
and
How are you
waiting.
doing? So I think you know Professor Nashar and Dr. Tracy as well. Okay,
Yes.
so may I introduce?
I saw her.
Yes, she was just here. Okay, so I think we approached. We are now 200 plus.
We are almost 200 now. So can we, Professor Mohammed, can you start, please?
Okay, can we start?
Yes, we can. Yes.
Are we happy to start? Okay. Okay, that's fine. Mohammed, start, please.
Yes. Good evening, everyone in this room. I would like to express my happiness and my proudness to be here today in this webinar conducted by the Marketing House and the Egyptian Representative Society, ERC-RCOG Egypt, to discuss a very common and very interesting topic, the menopause. What's new? What are the new treatments, new plans? How can we manage the menopausal symptoms? And we bring different experiences through all over the world to discuss this topic today. The panelists, the respected panelists, Professor Yasser Abu Talib, Professor Mark Prinkat, Professor Abu Bakr Nashar, and Professor Miss Tracy Louise. I would like to welcome all of you for this scientific night, and thank you so much for being with us despite your commitments, despite your business everywhere, your work, and your responsibilities. I know Professor Nashar is not in Egypt and he is traveling worldwide, and he is doing a very good job in spreading the knowledge of Obs and Gynae worldwide. Thank you, Professor Nashar, despite your commitment to join us. Thank you so much. And all other candidates and friends, colleagues who are there in this room today, I would like to welcome all of you. And I'm very happy and proud that I take the opportunity to introduce this important session. Now, the word goes to, the mic goes to Professor Yasser Abu Talib, the chairman of ERC-RCOG Egypt, the professor of Gynae and Ops, Ain Shams University, and Military Medicine College, and the very famous and landmark of Ops and Gynae in Egypt. Thank you so much, Professor Yasser, for your participation. Mike is yours.
Okay, that's fine. So, hi all. Hope that everyone fine, and we're doing our best actually to spread as much as we can from the knowledge and to contact everyone in the field of obstetrics and gynecology. It's our pleasure actually as IRC, International Representative Committee of the Royal College in Egypt, to participate with this webinar as a community service for everyone. We will be very happy to have a feedback from you and to receive your feedback. I think what we are going to discuss today is very important. Over the last 5 to 10 years, actually menopause starts to be ignored, despite being it's a very, very, very big issue all over the world. The number of menopause are increasing gradually, and I will present that in my presentation. And I think it's very common to have many problems with them. They are living long for about maybe 30 years or more. So as they represent huge number of population, I don't think it's wise to leave them without great support, because they used to support us for a long time before reaching to this age. So it's their right to support them and to help them in everything and to save to them a healthy, nice, sweet life. That's why we are doing our best actually to attract the attention and to regain the menopause to the center of vision for everyone, and discuss the issue, trying to find a solution and to put certain principle for management of this situation. Looking forward to satisfy every one of you. Please have a comment if you want to have questions, and send it to Dr. Muhammad Hassan, who is the treasurer of the committee, the IRC committee, and we are going to reply with the question because he is going to ask the question after in presentation. We will have 4 presentation. It's a great honor to have 4 of our colleagues with us today. Ms. Tracy, who is one of the leads in England in the field of menopause, and despite being busy all the time, and she was actually have a very long day in military service and the military service for in England. Despite all of that, she is spending long time waiting to conduct her presentation. So thank you very much, Tracy, and appreciating that very much for you. Thank you very much. As well, Professor Prenkat, despite being in Malta, and he's busy all the time, and he's sharing us in this presentation. And thank you very much. Looking forward to see both of you in Egypt over the coming meeting and Congress in December, the IRC Congress here in Egypt. And may I introduce as well Professor Dr. Nashar. He's one of the international reviewer, and I'm very proud to be a friend of him, and he's my neighbor as well. So thank you very much. I can see from the picture that you are, it seems that you are taking a bus from a place to a place, and despite all of that, you are sharing us in this presentation to support everyone in Egypt. Thank you very much for all the team, and looking forward to satisfy all of you. Okay, Mike is your Muhammad.
Yes, Dr. Yasser, thank you so much for this introduction, this rich introduction indeed. And we can start now with the first presentation and the first lecture with Professor Yasser Abu Talib, the professor of Obs and Gynae Ain Shams Medical School and Army Force College of Medicine, the recognized ERC-RCOG examiner and a consultant of assisted reproduction and IVF, the chairman of ERC-RCOG Egypt, with a very interesting headline: Menopause Replacement Therapy, Hormonal Replacement Therapy. Is it mandatory or not? And this is a very interesting question, so we need the answer from you, Professor Yasser, please.
Okay, that's fine. So let me to explain that menopausal, despite the fact that menopausal replacement therapy is nothing except hormonal type in the mind of everyone, but actually it's not. We have been through lots of debates regarding to the safety of the hormones and how it does work, and what's about its effect on the health of menopausal women. Some said yes, some said no, and at the end of the day, we become in a dilemma between taking and not taking. The worst thing that it was ended by, I am not going to take because I'm not going to disturb my mind by thinking very much with the complication that might occur. Okay, so let's go. Is it safe or not? What's that? What does it mean? Let's go through just simple things. Let's go through simple things. Let's ask ourselves to understand the principle of what we are going to say. What's menopause? Let's have a look to this picture. This is the ovary. The main component of the ovary is connective tissue. This connective tissue is nothing except a tissue which used to produce testosterone. However, this connective tissue holding a very important structures, which are the ova. This ova on growing produce estrogen, and when it pop out of the capsule, produce progesterone. So we have three types of hormones producing from the ovary: stroma from testosterone from stroma, and estrogen progesterone from the follicle. What does it mean, menopause? It means that cessation or finishing all or absent of the ovarian follicle. As a result of that, this side will disappear completely and this side will be left there. So we will have testosterone predominance and absence of estrogen and progesterone. And what's about the effect of that? We will have a physiological effect, which might be exaggerated in some cases to become pathological one. We know well that estrogen and its component, the active principle estradiol, it's very important for growing and support of the connective tissue and the collagen in the skin, hair, teeth, and bones. And on top of this collagen, there is another structure very important, which is the epithelium, especially in the genitourinary system. As a result of estradiol depletion, it will end up by atrophy in both epithelium and collagen as well. So as a result of that, with cessation of menstruation for between 6 and 12 months, and usually this occur between 45 and 51.9 years, this lady physiologically starts to be upset from certain problems. What are these problems? Headache, hot flashes, pendulous breast, teeth and gums recession, weight gain, backache, vaginal dryness and itching, and as well difficulty in intercourse, as well bones everywhere. We know that approaching the age of menopause, the lady reached to her maximum strength and maximum experience in the work where she is doing, and she is in need to a good health to continue and to keep giving and giving. Meanwhile, her daughter and sons left her just because they become just mature persons. So she will be independent woman. Okay, she is in need to healthy life. Okay, she is not in need to do these things just to affect her health. However, this might be accepted, and she will do her best to come over by some sort of regulating her diet, some sort of exercise, blah, 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 blah. However, sometimes, and because of the long exposure to absence of this hormone, this might be turned upon other things which are pathological risks. These pathological risks are hormonal dependent, which might end by morbidity of high cost. What are there? Moody changes, which might end up by loss of her work. Vasomotor symptoms, which make her upset and cannot do her work properly. Ischemic heart, which might end by infarction and ischemia and admission to ICU. Bone fracture, especially of the neck of the femur, which might end by mortality itself because of cut of the blood vessel and internal hemorrhage as well. Or if we catch her, she might end by fracture and disability, thrombosis, internal hemorrhage, and the great psychological killer, Alzheimer and the dementia. So how can we manage this situation if we have something which is deficient and cause manifestation, physiological and pathological? So the answer is replacement therapy. So this replacement therapy might be hormones, and this hormones is called hormonal replacement therapy in the past. Now it's called menopausal hormonal therapy. However, if we have some sort of contraindication because of some risk factor in this lady, we might offer her non-hormonal therapy. So menopausal replacement therapy might be hormonal, and if we have certain contraindication, might be not hormonal. And what are there? The hormonal one is the three types of hormone in the lady. It's estrogen, progesterone, and testosterone. And what's about the non-hormonal? We have 4 types of hormonal, and I think Professor Nashar is going to discuss all of them in details. It might be tepiolone, phytoestrogen, tissue selective estrogen complex, and contraception. I'm not going to deal or to discuss them in details because Professor Nashar is going to highlight this subject, and most probably he's going to add another thing. Meanwhile, I will discuss the hormonal one. So let's ask ourselves, is menopausal replacement therapy either hormonal or non-hormonal is mandatory? Is it important to be used or not? Okay, let's have just this introduction to understand the problem now. What's about the age of menopause? No one can deny that the age of menopause occurs in 95% around the age of 51. However, 5% of the menopausal women will go through menopause between the age 45 and 50. What does it mean? If we know that according to the International Revenue Service, in January in the year 2022, IRS life expectancy, the life expectancy of women range between 77 years and 83. What does it mean? It means that the life expectancy of women nearly reached to 80 years. So what's the significance? It means that the average lifetime where women will live in menopause 30 years. So if the average age of women all over the world nearly 80 plus, it means that after the age of 50, 30 years, this lady will be in menopause. It means that these ladies will expose to what we said actually for 30 years, not for just 5 years or 3 years, and no, for 30 years. Is that threat? No. Let's have a look to the CIA World Fact Book in the year 2000. 2021, who mentioned that the total number of the population all over the world is 7 billion, approaching 8 billions. Actually, I went through the new record and I found that it reached to 8 billion.2. 49.7 are female and the rest are males. Of this, if we know that 25 million women pass every year to menopause, it means by the age of by the year 2025, we will have all over the world nearly 1.5 billion women who will be menopausal, and all of them expected to live for 30 years in their menopause. What does it mean? So in conclusion, we will have 1 billion women who will live for 30 years with menopausal symptoms upsetting them, disabling them from working, headache, bendless tummy, bendless breast, bad shape, dyspareunia, backache, bony ache, vaginal drip, so they cannot enjoy their life at all. So they cannot produce good work. Not only that, but they are at high risk for morbidity because of hormonal deficiency in the form of ischemic heart infarction, bone fracture, internal hemorrhage, Alzheimer, and dementia. And all of these manifestations, either physiological or pathological, are hormonal dependent deficiency morbidity. And what's the answer? Are we going to leave them for 30 years with this complaint? Are we going to leave the 1.1 billion women all over the world, which is not actually the exact number? Most probably it's approaching 2 billion by the year 2025, for 30 years living and cannot give what they want, depressed with high problems, health problems? No, the answer is no. So what can we do? Just to give them the replacement therapy to antagonize all of these problems, either hormonal, and if we have contraindication, it will be non-hormonal. And according to the CIA, I tried to find, so if we have this huge number of women menopausal, how many of them are using this hormonal or non-hormonal replacement therapy? And again, according to the CIA World Fact Book, I discovered that out of the 1 billion or the 2 billion who will live for 30 years who are menopausal, only 23% are using hormonal or non-hormonal. So they are protective. What does it mean? It means that 77% of menopausal women all over the world are not using that. It means that 77% of the 1.1 billion people, women, will be at high risk to high morbidity from the physiological and pathological changes that we said after that. And let's ask ourselves with what we are presenting. Again, if we have huge number, which represents 75% of 1.1 billion women menopausal at high risk for physiological and pathological changes. So does it mean that, is it mandatory? Is it very important? Is it a must to use menopausal replacement therapy or not? And I imagine the answer, if we have to ask ourselves 3 questions. Number 1, does menopausal replacement therapy improve menopausal manifestation or not? So if it's improving, so I think it's mandatory. Is that it? No. The second one, does it protect against pathological risk of menopause? So in another way around, does it improve the physiological? Does it protect against pathological problems? Okay, if it's set, it will be good. And at the end of the day, so if the menopausal replacement therapy is improving physiological and protect against pathological, so does it mean that we are going to use them? No, we have to weigh the benefits against the risk of everyone. And we are going to discuss that in details over the coming one. So the first question is, does it improve menopausal manifestation and symptoms? No one can deny that Royal College Guideline, American Guideline, ASRAM and ESHRI agreed that the current rule of hormonal replacement therapy and menopausal replacement therapy controlling of other menopausal symptoms. But we have 3 items. We have to use the lowest effective dose to avoid complication with the higher dose. And the timing of using this hormonal replacement therapy must be as short as we can to avoid chronic use. Is that said? No. But all this organization put certain prerequisites to use this hormonal replacement therapy, which are by history, examination, and investigations. By history, we have to exclude risk of ischemic heart, cancer, blah, 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 blah. And you have to examine the lady. And the most important and the critical structure in her is the thyroid and the breast and the genitalia as well. You must examine all of this structure and be sure that all of them are fine. And every 1 to 2 years, you have to check the function of the organs. It means you have to do liver, kidney, CBC, mammogram and breast ultrasound, pelvic ultrasound, bone density, and smear test as well. If all of them are fine, so let's go for it. The other question, can hormonal replacement therapy prevent pathological risk of menopause? And the answer came here straight ahead. Actually, hormonal replacement therapy is not at all recommended for prevention of disease, except in 2 cases. Elderly, in cases under 60 years with increased risk of bone fracture, osteopenia, osteoporosis. So if we have a lady under 60 years and she is in high risk for pathological fracture because of anything, by measurement of osteopenia and 2 standard deviation or 1 standard deviation, osteopenia or osteoporosis. So using hormonal replacement therapy will protect against bone fracture. Okay. However, ladies with premature menopause under the age of 50 years because of long period of exposure to menopause, they are at very high risk for heart disease, osteoporosis, and some neurological conditions. So in this case, this using hormonal replacement therapy will protect against all of this. So 2 cases only. In 2 cases only, we can use hormonal replacement therapy for protection against fractures, protection against multiple diseases in young age. And it's recommended that the best way to use hormonal replacement therapy through the scan, transdermal. Why? Because of the first pass phenomena. If we use it through the scan, it will never pass through the liver. So the problems with thrombosis and production of coagulation profile will be less. So it's best for these 2 cases to be used transdermal. This is the best one. Okay, that's fine. So as we see now, we have the answer of 2 questions. Number 1, is it good for physiological changes and menopausal symptoms? Definitely it's good, with certain prerequisites, provided there is no risk factors at all. So it's very good because it will improve the situation. Number 2, is it protective against certain disease? No, it's not protective. However, it will be protective in 2 conditions only. premature menopause under the age of 50 to protect against all the hassles who are young ladies with premature menopause might be exposed, or under 60 years with high risk for pathological fracture, and it will be transdermal. Okay, that's fine. So let's go for it. And the answer is, what's the risk-benefit ratio? We have lots of debates since long time. I got back from England in the year 2000, where we have strong argument from two big studies, and we have debates regarding risk benefits of all of this: osteoporosis, ischemic heart, cancer colon, cancer breast, blah blah blah. I remember well that we used to keep in our mind the WHI study, WHI-MS study, 1 million study, okay? And all of them was done between late 90 and the year 2002. As we see here, this is the WHI study and this 1 million study. The 1 million study mentioned that HRT will increase the risk of cancer breast in this ratio. And the combined, this is estrogen alone, because we know that hormone replacement therapy, if we have a uterus, so it must be combined, estrogen and progesterone. Meanwhile, if we have no uterus, it will be just estrogen. In 1 million study, the risk of cancer breast using HRT was 1.5 increase. Meanwhile, use combined, it will increase by 1 up to 6. What's about the Women Health Initiative study? There was a risk of increased stroke, increased venous thromboembolism on using hormonal replacement therapy. However, if you use combined one, it will increase cancer breast as well. However, it has a benefits, which is short-term benefits. Using the hormonal replacement therapy for 2 years, improve the vasomotor symptoms. And long-term effect, if it's used for 5 years, it will protect against fracture neck of femur, cardiac problem, and colorectal cancer. This was the recommendation. Meanwhile, the risk will be ischemic heart, venous thromboembolism, strokes, and the cancer colon. Is it sad? No, because everything had been studied. Since that time, we have had a sort of a very, very big worldwide study all over the world. The EPIC study, European Protective Investigation of Cancer and Nutrition, which started actually in the year 1992 in France. Actually, it's still going, and it's nothing except multi-center European studies, including 23 countries, still gathering information and produce some sort of recommendation, and still doing that. However, they produce some recommendation and still gathering as well. It's a huge study, still working. It's EPIC study in Europe. On the other way around, the Far East has a Korean study, which was end after a long period of study, and published the results in the Journal of Menopausal Medical Medicine in the year 2020, and put a certain guideline. What are things had been changed? First of all, if you have a family history of cancer breast and your intention to use hormone replacement therapy, is it safe or not? According to EPIC study, using combined estrogen and progesterone is safe for 5 years. However, after 5 years, might increase the risk of cancer breast. And they recommend use progesterone as a hormonal replacement therapy instead of any other type of progesterone. What's about estrogen if you have hysterectomy? Can you use it? Okay. And the answer we can use it up to 15 years without risk factor. What's about tibulone? Okay. It has a minimal risk, less than estrogen, progesterone, androgen. What does it mean? It means that we can use. So it's safe to use for 5 years, combined estrogen, progesterone, safe to use estrogen for 15 years, safe to use to be alone in cases of family history of cancer breast. So it's safe. So what's about Korean study? Surprisingly, Korean study said, no, it's not 5 years. But using estrogen for 13 years, make it more safe and you can use it for life. So after 13 years, the risk of estrogen will decrease. What's about using estrogen progesterone in intact uterus? It's safe up to 7 years. But come raise to the point, a very important point. We haven't had any studies where cases with cancer breast use hormonal replacement therapy ethically. So there is no definite conclusion that using hormonal replacement therapy in cases of cancer breast operative are absolutely contraindication. That's why they recommended that menopausal hormonal therapy is not advisable. So we might use it. And I remember well when I was working back in England in Benenden Hospital, where I have had one of my patients which was about to die because of the menopausal manifestation, and she had a cancer breast and she was operated upon. Our decision and the consultant was just let her use it. So you might use it. What's about cases with cancer ovary? We remove everything and we have operative intervention. Can we use hormonal replacement therapy? Definitely. There is no or very minimal risk. 0.7 case in 1,000 for 5 years. So it's very rare. So if you have total abdominal hysterectomy or exoneration and you remove everything, appendectomy, omentectomy, and so on with cancer breast, with cancer ovary, so you might use postoperative hormonal replacement therapy safely without problem. What's about cancer endometrium? If you have cases with cancer endometrium with low risk stage 1 and 2, minimal invasion of the myometrium, less than 50% of the myometrium, use it safely after total abdominal hysterectomy, bilateral salpingo-oophorectomy. However, they have a reservation regarding use hormonal replacement therapy in high grade, stage 3 and stage 4. And the studies, both of them, recommend not use the hormonal replacement therapy, but use non-hormonal one. It's more safe. So in cancer ovary, use it, whatever the stage is. In cancer endometrium early stages, use it. In cases of advanced stage, it's preferable to use non-hormonal one. What's about colorectal cancer? Post-operatively, can you use hormonal replacement therapy for women? It had the advantage of using combined hormonal replacement therapy to reduce the risk of cancer of recurrence. However, estrogen does not have any effect. So in case of, if you have a lady with cancer colon and you have resection or whatever you have done for her to relieve her from cancer colon, use the hormonal replacement therapy. If the uterus is there, combined estrogen progesterone will reduce the risk. Meanwhile, if the uterus is not there, use the estrogen without risk at all. Let's go for the 1 million study which warned against thrombosis and strokes. If we have a lady with cardiovascular effects, strokes and thrombosis, strokes, can we use it? Yes, we can use, but lower dose oral hormonal therapy or transdermal. So if you have a stroke and the patient under treatment, you might use hormonal replacement therapy, but try to reduce the dose, especially if you are going to use the transdermal one to avoid its effect on the liver, so you can avoid thrombosis as well. This will markedly reduce the risk. What's about the venous thrombosis? There is a difference, between strokes. It means intracranial hemorrhage and thrombosis or venous thrombosis, DVT or superficial thrombosis. And so we would prefer not use. But if you are going to use estrogen transdermally. Why? To avoid passing through the liver to produce more coagulation factor. So in cases of strokes, use. In cases of thrombosis, you might use, but transdermal while. Till now, as we see, there is no risk. So we can use it after cancer ovary, cancer endometrium, low grade, cancer colon, and so stroke, cardiovascular problem as well. What's about migraine, depression, and weight gain? All of these subject use. Okay, you can use it completely safely. So there is no relation between hormonal replacement therapy, migraine, depression, and weight gain at all. Okay, sometimes some said that it might cause weight gain, but again, we said benefits against risk. What's about the gallbladder problems? This is the problem actually. Okay, why? Because the problem, if we use estrogen or estrogen progesterone through the oral route, it will pass through the liver because this is the metabolism there. This will increase the risk of gallbladder stone. So the only thing that we have limited use if we have cholecystitis or gallbladder stone. We don't prefer to use hormonal one. So what to do? Are you going to do another thing? Yes, you might use non-hormonal. So the only use for non-hormonal now, for all what you said, two things. Advanced stage cancer endometrium after hysterectomy, so non-hormonal. Apart from that, you can use whatever. And as well, gallbladder disorders. What's about genitourinary syndrome and menopause? We know that DHEA may be effective in treatment of genitourinary syndrome and as well spumifen and estrogen receptor agonist antagonist 60 milligram once a day. It's very good for menopausal manifestations. So in non-hormonal replacement therapy, so what can we say that all of that we discuss that the hormonal replacement therapy. So what's about hormonal replacement therapy? It will be good for cases with problem in the livers, gallbladder disease, cancer breast, advanced cancer endometrium. Apart from that, imagine, close your eyes and imagine, and you can use it completely safely. Which are non-hormonal in this case in liver, gallbladder, cancer breast, advanced cancer endometrium. You might use non-hormonal, which are tipilone, phytoestrogen, tissue selective estrogen complex, and contraception. Ladies and gentlemen, distinguished guests, colleagues, and professor, let me to wrap up or to lump sum what I said actually. Over the last 5 years, we forget menopause, which is a very, 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 very unique, very important problem. Don't forget that nearly 1 billion, actually it's not 1 billion, it's 1.5 billion women will live 30 years in their life in the menopausal period, where they are at higher risk for hormonal dependent morbidity due to deficiency and menopausal symptoms. Hormonal replacement therapy is used to relieve menopausal symptoms, not for disease prevention. It's mandatory to use hormonal replacement therapy in premature ovarian failure before 50 years, and as well under 60 years with high risk for bone fractures. Using non-hormonal replacement therapy instead of hormonal replacement therapy in the following conditions: liver disease, gallbladder disease, cancer breast. However, cancer breast, it's not a must. It's from the ethical, we have not enough study to say that using using hormonal replacement therapy with cancer breast is safe. And advanced cancer endometrium stage 3 and 4. hormonal replacement therapy and cancer breast. If you have a history of cancer breast and a family history of cancer breast, combined estrogen and progesterone is safe for nearly 7 years. Meanwhile, estrogen, if the patient had hysterectomy, is safe for more than 15 years. HRT, not advised, but it's not absolutely contraindicated. It's not advised in cases of cancer breast who had operation and had severe menopausal manifestations, so it's advised not to use. However, there is no conclusive evidence to increase recurrence with HRT uses. Hormonal replacement therapy is safe in positive family history of cancer breasts, vascular accident, cardiac problem, after hysterectomy in cases of cancer ovary, and after hysterectomy as well in cases of low-grade stage 1 and 2 cancer endometrium. And as well, hormonal replacement therapy does not have relation with weight gain, migraine, and depression. Ladies and gentlemen, let me just to ask everyone some question and ask myself as well after I discuss the situation from the evidence-based view. Now, is it mandatory to use menopausal replacement therapy, either hormonal or non-hormonal, in menopausal women? This is up to you to take it or leave it, but I'm not going to answer. So the data that I present come from all of these, from ESHRI, ASRAM, from the Joint Anesthetic, and from the National Institute of Health, Royal College of Obstetrics and Gynecology, and Chapter 92 from consensus review arising from the 47 study and the group of menopause hormonal replacement therapy. Thank you very much. And if you want to have any question, the microphone is with you, Muhammad. Thank you very much.
Thank you, Dr. Yasser, for this very smart, shortcutted presentation regarding the debates in menopause. And we have just one question. I would like to ask you, please, if you give me a proper answer regarding this. We have a patient. If we have a patient, she had a menopause around age of 45. And now she's 48. She didn't receive any treatments. Okay, so can we start with her the hormonal replacement therapy after 4 years of menopause, even if she had some symptoms still bothering her?
Definitely. Let's go back to what we said, Muhammad, because she has a sort of premature menopause before the age of 50. So she will have a so we said, actually, if we have, it's not preventive for diseases except in 2 cases: under the age of 60 with the risk factor for osteoporosis and premature menopause. So she can start definitely. And if she had a sort of hysterectomy, we might offer her estrogen. If we have the womb in place, we might have cyclic estrogen progesterone. However, if she is worried about using the hormones, we might use non-hormonal. It's not hormonal exactly. However, we can still use at the end of the day because it has a great effect for, in this case, especially for protection against other diseases and as well for lifestyle as well.
Yeah, very logic. Thank you. So, and another question that you mentioned contraception as like one of non-hormonal management for menopause. So can you explain more, how can we use this method instead of the regular hormonal replacement therapy? I mean, the use of contraception.
That's fine. Muhammad, do you remember when we have menopause, actually it might be false menopause. What does it mean? Stoppage. For example, if we have FSH of 30, or 50. Does it mean that the woman is menopausal? No, it might be resistant ovary syndrome as well. High prolactin level, disturbed thyroid, lactate, anything stop ovulation. Okay, factors stop ovulation. So this woman will be deprived of the hormones in her body. However, we don't know at which time ovulation will be resumed, right? So in this case, we might use combined oral contraceptive pills with dual action. Number one, to supply her with the estrogen and progesterone. So it's considered as hormonal replacement instead of the estrogen and progesterone produced from the ovary. That's number one. Number two, and add a method of contraception as well. That's why we might use it. As well, ladies used to use combined oral contraceptive pills near menopause. Okay, if they are on regular use of hormonal on use combined oral contraceptive pills, so we will never discuss or discover that she went through menopause, because definitely menopause is nothing except absence of menstruation for 1 to 2 years. Agree with me? Okay.
Yes.
But she's using oral contraceptive pills on regular basis, and oral contraceptive pills as well cause marked reduction of FSH. So we don't know at which time she went through menopause. So in this situation, we are protect against menopausal symptoms and use contraception, especially in the perimenopausal period.
Yes, thank you so much. The last question is, I'm a 42 years old patient. I had a bone marrow transplantation because of leukemia since many years, around 15 years ago. I suffer from ovarian failure right now. And is the HRT being safe for me or not?
Let me ask you the question in another way around. Okay. Mohammed, do you think estrogen and progesterone has an effect on the bone marrow?
Up to my knowledge, I don't think so.
That's right. Okay. Let me ask another question. In cases of hemolytic or hemorrhagic disorders, lymphoma, leukemia, thalassemia,
aplastic anemia, all of these stuff. Yeah.
Yes. So does it be affected by hormones? No. The only thing that might be affected not by hormones, by chromosomes. It's hemophilia. It's not hormonal. Okay, it's chromosomal because it's Y or X linked, as you know. But even for hemophilia, it's unrelated to the hormone. It's related to chromosomal defects, which will affect and make the lady liable for bleeding tendency. Okay, but it's not hormonal dependent at all. As far as I know, that there is no definite relation between hormones and the blood disorders. If she is in need to hormones, she might use. As I said to you, I was working in Benenden Hospital back in England long time ago, and one of our patients with extensive cancer breast, she was about to kill herself because of menopausal symptoms, and we made up our mind with our consultant to use hormonal replacement therapy because there is no definite studies said that we have patients with cancer breast and we give them hormonal replacement therapy, but it's just an ethical problem. So again, we are weighing the benefits versus risk. Okay.
Yes, perfect. So yeah, I got the point. So we have a lot of questions actually, but I will try to summarize them. In one of our colleagues just asking, if we started HRT treatment, within how much time we can expect the effect on the woman?
That's fine. So it's variable, Mohammed, according to the metabolism. But the old recommendation is to start HRT as early as possible. But the recommendation as well, if you are going to deal with the menopausal manifestations, keep using hormonal replacement therapy. I'm speaking regarding to the hormonal one, not with the non-hormonal one. Keep using it at least for 2 years. And what's about if you are going to use it for long-term effect and to protect against bone problems at least for 5 years. After that, you can stop it or keep using it. Why? Because hormonal replacement therapy will have an effect on the osteoplastic activity, which will catch the calcium and the phosphorus from the blood and deposit it in the osteoclasts through the osteoclast and reduce the activity of osteoclast. Over the 5 years, it will cause marked deposition of huge amount of calcium, which will be act as a storage and reserve for longer time. Okay, so don't stop it, because before 5 years, if you stop it, loss of calcium from the bone will be fast. This is an old recommendation, by the way, not new one. But
perfect, sir. So yeah,
she can use HRT for her life, no problem.
so yeah, this is typically answering the next question. If a woman is age 60 and she suddenly have some symptoms, or she diagnosed with osteoporosis or osteomalacia, can she start HRT safely after the age of 60? So I think you, sir, answered this question clearly. Yeah.
But Muhammad, keep in your mind, again, we are not going to give HRT as a treatment for the osteoporosis. No.
Yes,
no,
typically,
no.
yeah.
No,
The bisphosphonates will be the idea.
Yes, yes, she's going to be managed. If she has another problem, she might, because she's delaying now. Okay, so we used to use hormonal replacement therapy with the start of the manifestations. However, if 10 years passed and she's menopausal and no manifestation, okay, so forget about it. We are not in need, but just for healthy things, use calcium. If she develop other disease, so the treatment will not be HRT, because HRT is not protective against these diseases.
Yeah, and finally, if the woman is still perimenopausal, yeah, not yet diagnosed with menopause, and she started to have some symptoms like vasomotor symptoms, which is very common around the age of 45, can we start the HRT even before definite menopause?
Let me explain just one thing, Muhammad. Menopausal manifestation or hot flushes or something like that, we cannot guarantee that the cause of it is hormonal deficiency, because thyroid problem might cause, psychological disturbance may cause, vitamin deficiency might be the cause. Okay, however, she can use it at any stage, but before just rushing and use HRT, okay, be sure that there is no another. So just use the vitamin. I remember when that folic acid is very important. Vitamin B will improve, and I remember that one study in Alexandria University mentioned that 20 microgram of folic acid a day might improve, like menopausal, not menopausal, but hot flushes and some. So be sure that the cause is absent of estrogen, which is associated with amenorrhea. But if she still have some sort of regular menstruation, so these manifestations, it's not referred to hormonal deficiency. So
I got
try
the
to
point.
check the question. Yeah, yes.
Thank you so much, Professor Yasser Abu Talib, for this amazing presentation. We got a lot of information, and I wish our colleagues in the room got the same information, valuable information regarding how to think about menopausal symptoms and proper using of hormone replacement therapy. Thank you again, my dear Professor. And yeah, thank you. I am so much pleased to go for the next session, I mean next lecture, with Professor Stacey Louise. She had a very large biography, actually, but I will try just to say the most important things. Ms. Tracy, ERC-RCOG consultant, Obs and Gynae, a lead consultant for colposcopy and women's health, South Mid Hospital, North Bristol, NHS Trust. As I said, the biography is so much rich. She had a lot of positions in Bristol, Queen Charlotte's Hospital, London. She had also special interests in colposcopy, pelvic pain, and menopause in particular. She served over than 30 years either in UK and in other hospitals overseas. And she is the deputy convener of a basic practical skills course by the ERC-RCOG, and regularly teaching obs and gynae specialists how to manage different kinds of emergencies as well. Miss Tracy, are you with us? Good evening.
I am, and thank you very much. Alaikum. And thank you very much for inviting me to talk this evening. Can you hear me?
Yeah, we can hear you. It's our pleasure to have your presence with us today as a valuable doctor in the field of menopause and other fields, of course, but we will gain the maximum benefit from your rich knowledge.
Okay, so that's great, and I've seen there's a huge number of participants on the for this webinar, and thank you very much, Professor Yasser. How to follow that, and I was going to make mine quite brief. I'm going to try and share my screen now, and hope that it works. IT is not my forte. Let's see how we go.
The screen is clear. Yeah, we can see that. Thank you.
So the only thing I would say is that I need to get back to the beginning of my slides. So if I stop sharing screen now, let's have a go again. And I'll just get back to the beginning of that thing. Hang on. Otherwise, we're going to be here all night with my slides. So here we go. So let's find you again. And now you've all disappeared. Let's have a look. Okay, so go back to Zoom and I'll share my screen again. And let's hope this now works. Share. So, can you see my slides?
Yes, we can.
Brilliant. Thank you very much. So I was asked to present on a subject related to menopause, and I chose unscheduled bleeding on HRT, which is a particularly hot topic within the UK, and there's been a new guideline, so I was hoping that I'd be able to sort of inform you of that. So as my kind introduction said, I work at Southmead Hospital in Bristol, and also Queen Charlotte's Hospital in London with Professor Panay, who's one of our leading menopause specialists. My declarations of interest, and I think the only one that's really important is that I take HRT, and I make that no secret. I wouldn't be able to function without it. So today what I'm hoping to do is to just briefly describe the size of the problem, the definition, how we stratify risk for the management of these patients, the pathways that exist within the UK, some investigations and some strategies to see if we can help. So it's always really good for somebody to define the problem, because you know what doctors are like, and should you ask 5 of them, you'll get 5 different opinions. But this has now been defined in our latest guidelines. So it's irregular bleeding. It occurs after initiating HRT or when we change the formulation or the dosage, and it's for both continuous combined and then for women who have intermittent bleeding in between their scheduled monthly bleeding whilst taking sequential or cyclical HRT, depending on what you wish to call it. And I've used HRT throughout my talk as my definition. Now, the most important thing is to highlight that irregular bleeding on HRT is not the same as postmenopausal bleeding. It doesn't carry the same background risk of endometrial cancer. But in the UK, until pretty much this month, this whole investigation strategy profile has been the same as if women had had PMB, postmenopausal bleeding, not using HRT. And this has been to some cost. So how common is unscheduled bleeding on HRT? Well, we know it's exceptionally common in the first 6 months of initiating HRT and starting it, and certainly within a 3-month period of either changing the dose or the preparation, and up to about 40% across the type of HRTs. Why has this been a problem? Well, within the UK, we've really struggled with supply. So many women have not themselves chosen to change their HRT formulation, it's merely because the one they were using has run out and not available, and we've had to change their formulation. But also there's a lot of buzz about HRT and what is deemed to be the best form, and women are flitting between preparations. What problems has this caused? Well, huge problems, absolutely multiple consultations. Our service is overwhelmed with women coming in with unscheduled bleeding, and they've been on a cancer pathway, suspected cancer pathway, which we call a 2-week wait, blocking up our service, requiring us to see women, or at least aim to see them within 2 weeks, much to the dismay of the rest of our service. The other thing is that this bleeding has sometimes prompted either the women or the doctors to recommend they stop HRT. I'm not a huge fan of stopping HRT, and a sudden cessation of HRT actually increases your cardiac events profile, and you're more likely to have an MI. So I don't like stopping HRT abruptly. But certainly within a resource limited environment, it uses resources. So the size of the problem within the UK, Professor Yasser brilliantly explained the number of women we have in the world and those that are likely to be in the menopause. Well, between 2021 and 2022, we had a huge 35% increase in the use of HRT in 1.9 million women. And what was also profoundly noted was the change in for preparation. So prior to that, often oral HRT was used, but now the most common one used, or popular one used, is estradiol gel, whether that be Sandrina or estrogel, and micronized progesterone, which frequently was under the name of Utrogestan, but there is a new kid on the block. It's still micronized progesterone, and it's called Gypretics. Not easy to say, but Gypretics is £2 a packet cheaper within the UK, and certainly is being used more widely. But what was seen was that there was a 125% increase in the usage, and this caused huge problems last year when we basically ran out and Utrogestan couldn't be found, and then Gypretics came on the market. So this really was a crazy thing, again requiring us to change women's formulation of HRT. At the same time as all these women using HRT, though, there was an enormous increase in unscheduled bleeding, that's what USB is, and the amount of referrals coming in on the fast-track pathway, the urgent suspicion of cancer pathway, and it increased by 43%. Now, given that we're trying to catch up with our waiting lists from the COVID pandemic, etc., this really just drowned our service. But what was noted was actually only a 2% increase in the number of diagnosed cancers. So the referral rate coming in was not actually increasing the diagnosis of cancer, and therefore asked us to look at whether this was appropriate that they were being seen. There is an impact of this as well, because whilst they're drowning the service, those women with a higher risk of cancer were not being able to be seen within the required time frame, and it was causing delays. But why were women using HRT? Well, I think because they're well informed now, and certainly HRT has many health benefits, which you've just had beautifully explained to you. But in 2015, NICE produced a guideline. It was slightly more sympathetic to HRT, given the horror of the women's health study, which put everybody off, along with British media and the Daily Mail, if anyone is aware of that newspaper, but it usually uses headlines as opposed to facts. And it frightened everyone into thinking that HRT equals breast cancer. But what we noticed as well is that there's been an increase in the number of perimenopausal women. So those women within the time frame of the menopause, but not actually in the post-menopause, and so still having periods, and therefore generally in their sort of 40s that decade. And they're using HRT, and they're a problem in themselves because they usually have periods, they have irregular periods, and then we're using HRT on top of that, and that was increasing the amount of irregular bleeding. Media actually, to some positive, I guess, were highlighting the benefits of HRT, but generally on the back of celebrities, the most famous being Davina McCall, who did 2 TV programs for Channel 4. They're definitely worth a look if you haven't seen them, because they're what's available to women, and the sort of thing that women are talking to us about. But also there's some private providers within the UK who've got huge social media accounts, and they were enthusing women to use HRT, and it took off in a sort of, almost hysterical style, really. Now, there's also the introduction, or not introduction, but the more widely used transdermal estradiol and the knowledge about that, which said it carries no increased risk of VTE or cardiovascular risk, cerebrovascular risk, was allowing more women who previously would have been excluded from using HRT. So women who've had a previous VTE, maybe be overweight or other comorbidities. And so those women are also using transdermal HRT. And those women themselves have an increased risk of endometrial hyperplasia, some of them. And so that was also causing a problem. And then there was, and this is quite a current theme, is off-license prescribing of what's called high-dose HRT, but without the prerequisite of increasing the amount of endometrial protection through progestogen. And whilst this looks like some women are taking high-dose HRT, when you actually do blood results, so serum estradiol levels on these women, some of them are merely not absorbing the HRT. So whilst they might be using something like 3 milligrams of Centrina a day, and the upper limit for licensed dose is 1.5, actually when you do the estradiol level, it might be sitting about 150. And so whilst they appear to be using high-dose HRT, they're not actually absorbing it. But it is thought that this has been causing some of the problems with a lack of endometrial protection. The other thing is that with the use of micronized progesterone, so Utrogestin, Gepretics, when that is used, it's usually used as a single product alongside a single estradiol product. And when you start to give women artistic license, so they're using 2 products, they can get muddled about which to use, which not to use. And certainly when women ran out of the micronized progesterone, some of them continued to use the estradiol products and were basically using unopposed estrogen, which I'm sure we're all aware is not a positive maneuver. And so that was causing problems. And also people got muddled up about dosage, and sometimes we're getting confused. So these are the problems that then made the organisation of British Menopause Society produce what is going to be, I think, a life-changing guideline. So this was produced by the British Menopause Society, but you can see at the bottom, it's been supported by the BSGE, BGCS, FRSH, and the GERFT organisation, who get it right first time, and also the RCOG. And today it was also approved by the Royal College of General Practitioners. So it's been hugely populated and has got a lot of stakeholder buy-in. It's also a totally fantastic guideline, and a friend of mine wrote it, so I'll just highlight that bias, but she also works in Bristol. Now, I love a guideline, but if anyone knows me, I also like the executive summary of a guideline. This guideline's 47 pages. I bet about 30, some of them are actually the guideline, the rest are references. But I do love an algorithm, or like I say, an executive summary. So this is an algorithm, which I'm not expecting you to be able to read on here, but it just beautifully depicts how you would manage somebody coming in with unscheduled bleeding. So in the first instance, we're going to look at this bit. And what it does is it highlights what you should do when you see somebody with unscheduled bleeding. And there's a few things really. One is to identify what type of HRT they're using, how they're using it, what's the regimen, and look at compliance, because compliance has been quite an issue. So I saw a lady not that long ago, who told me that her HRT regimen consisted of some perfume, a moisturizer, and a patch. I was a little bit confused. I wasn't aware of perfume form of HRT, but actually what it was Lenzetto spray. I don't know, again, if any of you are aware of that, but she was spraying that on. She was also using the moisturizer, which is actually estrogel, and then applying a patch. And she'd got all 3 of these formulations because during the shortages, she was given different versions when each of them ran out. And then she wasn't aware that she couldn't use them concomitantly. And so she was using those, but absolutely no concept that her progesterone was to be increased accordingly. So it's really important. Some women are also not applying their gel properly. They're getting dressed too quickly afterwards. It might as well be just rubbed onto their jeans, not changing patches properly or changing patches too frequently. So that's really important. It also highlights looking at cancer risk factors, and I'll talk about those on my next slide. But importantly, and I've just stopped being the fast track 2-week wait lead in Bristol, one of the important things is to offer an examination. And this isn't always done. Some clinicians merely think the problem with the endometrium and offer an ultrasound scan, but it can be that they've got a cervical problem, cervical polyps. They may be delayed with their cervical screening test, and so we would advocate that to be done. Genital swabs, and in the perimenopausal women, it's always really important to check pregnancy. So in my world, all women are pregnant till proven otherwise, and certainly in the perimenopause, bleeding problems can be associated with that. So it does mention on this slide here that you would want to assess major and minor risk factors. Again, I'll go through that on the next slide, but it's very clear with very precise recommendations on here of what to do with what time frame, and highlights the abnormality, which I will talk through as we go through the talk. Oh. Doesn't want to go through my slides. So if we go back to that, we're going to look at the bottom bit now. And this, I think, is not everybody is aware of these risk factors. So whilst you're on HRT, there is also some personal risk factors for endometrial cancer, and some which come with the HRT. And the most important risk factor is having a BMI greater than or equal to 40, and a genetic predisposition to cancer. So endometrial cancer, such as Lynch syndrome, which can give you a sort of 30 to 60% increased risk of endometrial cancer before the age of 50, and Cowden syndrome, which is a really rare condition. About 1 in 200,000 women can have that. It's associated with hamartomas, but also gives women an increased risk of 80% chance of breast cancer early, which is terrible, and then a sort of 20 to 30% risk of endometrial cancer. So that's just something to highlight. And with the minor risk factors for endometrial cancer on the right-hand side of the page, having a BMI between 30 and 39 is an independent risk factor. Having a background history of polycystic ovarian syndrome, liver disease, and diabetes is also the same. So with those ones that I've highlighted there, those are ones that are independent with the woman, and the rest on there are all associated with the HRT regimen or type that they're using. But anyway, it's beautifully depicted in the guideline, and I can't recommend it highly enough. If we do a little quick reminder of endometrial cancer, so all the fear about HRT previously was about breast cancer. And I think because we've got better studies and we are aware about risk of breast cancer, but we now realise that some of the breast cancer risk may be associated with the type of progestogen that's used and not merely the estrogen component of HRT, we're now focusing on endometrial cancer. It's the 4th most common cancer in women in the UK. And with women who are not on HRT but have postmenopausal bleeding, about 3 to 10% of those women will have cancer. The incidence increases with age, the peak being in the early 70s, and this genetic predisposition that I mentioned. But I did also talk about the BMI being over 40, and in 40% of women with endometrial cancer, their BMI is over 40, with a 10 times increased risk. And the BMI being over 30 doubles your background risk of breast cancer, and then also increases the risk of endometrial cancer. So if we can do anything in this world, it would be to aim to optimize lifestyle factors, which would then reduce overall risks for women. Now, what we could highlight here, though, is that if you're using standard dose combined, continuous combined HRT, and you have no abnormal bleeding, then actually your risk of endometrial cancer is reduced in comparison to women who are not on HRT. So that is a resounding bonus. And given that I love HRT, I do highlight that one. However, sequential HRT or cyclical HRT used over the age of 45, we've heard that you need to consider changing to a combined preparation, continuous combined preparation after 5 years or over the age of 54, because there is a slight increased risk in endometrial cancer in women who continue to have an endometrium that thickens or thins. Cancer loves cells that actively divide and shed, and much less likely to hang around in cells that are very stable, such as those with continuous combined HRT. So yes, whilst I have a love of menopause and all things menopause, it has got a little bit confusing, and it's always been described as an elite sport for some gynecologists, when actually I think having these tools available in this guideline will mean that more people, more specialists will be able to accurately assess HRT use and make recommendations. So brilliantly, there is this table included, which explains what the different dosages are. And it's really important to understand the equivocal doses, particularly when when formulations run out. So if someone was using estrogel and then it ran out and you needed to put them on a patch, this table, for example, would have been very helpful to my colleagues, who then would have been able to accurately assess the change, because for some women, they were merely put on an entirely wrong dose change. So they might have gone from 1 pump of estrogel to 3 milligrams of oral estradiol, merely because clinicians were not aware of the changes. And high dose estrogen or estradiol, the only ones that are truly licensed is 4 pumps of estrogel and 100 microgram of patch, and the rest is all off license. But, you know, we use a lot of medications off license in obs and gynae, don't we? Now, the other thing that comes with this is people got very confused about the equivalent dose then for progestogen, and people are aware of standard doses, which is very much the second line on this chart. And then people were not aware that if you increase the estradiol dose, then you should be mindful to consider to increase the progestogen dose. And again, this beautifully depicts this. And again, if you have a look at the document, you will have this at hand. But the one thing which is truly remarkable, where you don't need to remember anything about doses, is the LNG-IUD, most popularly the Mirena, but of course other sources are available. And so LNG-IUD, as long as it carries 52 milligrams of levonorgestrel in it, is also approved for endometrial protection, whereas Mirena is the only one that's licensed. Others can be used and are supported by all our organisations. It's licensed for 4 years, but we absolutely approve it being used for 5. So the important thing about using progestogen, and one of the reasons that women have irregular bleeding, is that some clinicians, again, have not been aware of the minimum doses that would need to be used. So if you're using norethisterone or medroxyprogesterone acetate, Provera, you should use, if it's on a cyclical basis, it for a minimum of 10 days per 28-day cycle. And if you use it for less than 10 days for over a year, that increases your background risk of endometrial cancer up to 3 times in some studies. Micronose progesterone, whilst being a lot more user-friendly and women love it, and I'll explain why in a second, actually you need to use it for longer. So the minimum time per 28 days is 12 days. But it's difficult to remember this. It's difficult to get women to remember this. They're in a bit of befuddle anyway, because they're in the perimenopause or menopause. And so easier regimens are available. And a really popular one to use is to merely recommend that women use their progestogen component for 14 days each 28 days. And we call it a 14 days on and a 14 days off regimen. And merely 2 weeks on, 2 weeks off, and it just makes it a bit simpler. But a lot of problems come with practitioners not prescribing the progesterone at the right time in the cycle. So if a woman is having her cycle, then you use day 1 as the first day of bleeding, and then on day 15 of a 28-day cycle, you would start your progesterone and continue it for 10 or 12 days. And again, this can be muddling, because some women then wait for their next period, but continue to use their estrogen, and then only start the progesterone in their next period. But if you're in the perimenopause, it can be 3 months before your next period aligns. So it's really important, I think, to only recommend day 15 in the first month. So what I mean by that is, say I was about to start HRT today, and then my day 15 was, say, the 15th of May. Then on the 15th of each month moving forward, I'd set my alarm on my or an alert on my watch or phone, and I would then take my progesterone, regardless of my cycle. And after a few months, you should settle down, and that should equate to your day 15 of a 28-day cycle. For continuous combined preparations, obviously, there's no need to be mindful of that. You use it on a daily regimen. But of course, again, the old favourite, the 52 microgram levonorgestrel IUD, you can just shove that in, place it carefully, obviously, and that would give you continuous cover. And actually, whilst this is an evidence-based guideline, they do highlight there is limited data about the optimal dose of progestogen. So it's a sort of sensible thought that if you increase the estrogen, you would need to increase the progestogen. But certainly for those of an academic background, there is room for research in the area. So what investigations would you do for somebody who's got unscheduled vaginal bleeding? on HRT? Well, currently in the UK, they've been managed on a urgent pathway within the 2-week wait. So they've usually been referred into a oncology service to have a 2-week wait scan and assessment. And this guideline highlights that that's not necessary for all women. So as long as they meet the criteria on that algorithm, you can organise a transvaginal ultrasound scan within 6 weeks, should that be what's recommended in your area. And where I work, that's not possible currently, although hopefully will be soon for GPs. Otherwise, they need to refer them into a gynae service within 6 weeks. So that is for service providers to work out what's best for their organisation, but certainly they don't need to have a scan within 2 weeks. Now, if they have one major or 3 minor risk factors, so say she's BMI over 40, or she's got a BMI of 35, polycystic ovaries, and been using her HRT in an indiscriminate manner, then we would recommend a 2-week wait pathway for them. It's quite clear, and I think that's really helpful, to stop the discord that happens in different hospitals in different regions in the UK. Now, the other thing that it absolutely recommends is there is no need to stop the HRT. If somebody stopped my HRT rather abruptly, I would feel considerably anxious. And if I was on a 2-week wait fast track being told I might have endometrial cancer, I think the combination of the two things, whilst increasing my cardiac risk, would not be positive. So you are allowed to continue to use the HRT whilst investigating, which is a revelation. Now, the other thing is that, again, in different organisations, and I've worked widely around the UK, in some hospitals, the endometrium was above 5 millimetres, then you did a biopsy, and if it was above 10, and so they very clearly recommended, if you are on continuous combined HRT, the endometrial thickness should be less than 4 millimetres. If it is more than 4 millimetres, then that means you need a biopsy, and we would recommend you're seen in a fast-track referral for that. If the endometrial thickness is above 7 millimetres and they're on sequential HRT, again, to be referred on an urgent pathway, because the chance of there being endometrial cancer needs to be excluded. And historically, what happened was women had bleeding on HRT, they were advised to stop their HRT, and if still bleeding at 4 weeks, then referred on a 2-week wait pathway. And again, that does still exist here, but what they recommend is you don't abruptly stop HRT, you consider weaning off. And if the bleeding is still continuing 4 weeks after that, then you would consider referral for a fast track, because there is a chance that there is some endometrial pathology. So what scan findings can there be? Now, wouldn't it be lovely if the only scan finding you had was endometrium is clearly delineated and either above or below the recommended thickness? But that's never the way in medicine. And again, this guideline beautifully helps with that, because what it's done is it's explained that if you can't clearly see the endometrium, although it does look to be in normal limits where you can see it, then they would recommend you do have an endometrial assessment, and that would be with a hysteroscopy, but within 6 weeks, and not a knee-jerk having to organise a biopsy within 2 weeks. So that reduces some of the pressure on the service. It also does highlight, whilst it's a guideline about women bleeding, there are some women who have an ultrasound scan done for other reasons. Maybe they have tummy ache, abdominal pain, and they've got no bleeding, but the endometrial thickness is above 10 millimetres. And if they have no bleeding, the endometrium is above 10 millimetres, they do recommend that you refer an endometrial assessment within 6 weeks to a service for that. And we do recommend a biopsy. If, however, there's no bleeding and the endometrium is above 4, above 7, and they have 1 major or 2 minor risk factors, then they should be referred urgently on a fast-track referral, whereas the other one above 10 is to be done under a 6 week. So what it's done again is it's trying to stratify the risk and then not have everybody come in on the same pathway, which drowns the service. Another popular request I get, I'm lead with a colleague for something called Advice and Guidance, where we advise and guide our GPs through an email type service. And this is a frequent one. I've done a scan and there's fluid in the endometrial cavity. And what's beautiful about that normally is you can see the endometrium. And if it's normal, then what you need to do is look for other symptoms. It doesn't mean there's no malignancy. Well, I'm sure we're all aware that clear cell problems can cause this sort of thing, but also simple benign things such as cervical stenosis can do that. So assess other symptoms and then consider referral to urgent gynae service. Now, if the endometrium's thick, you would just refer. Now, the other thing that can happen is that you can have women who have a normal endometrial thickness, but they're recurrently having this bleeding. And if after adjusting their HRT, it still continues for 6 months, then we recommend that, again, these women come in for an endometrial assessment, which is usually hysteroscopy, within 6 weeks. And these women are usually more likely to have polyps. So endometrial assessment, again, that can differ depending on the service that you're working within. And some people do a blind biopsy, where we do, which is an endometrial papille sampler, for example, or hysteroscopy. And a blind biopsy has many advantages to it. It's quite quick, it's cost effective. It does have a failure rate, and from some of my colleagues I explain that's because they haven't actually got the sampler out of the packet, and if they don't try, then of course will fail. So we do try to encourage using it, but it also has an inadequate biopsy rate of up to 22%, and there are cost issues for laboratories with that, because you're sending them samples and the sample's inadequate, and then you have to see the woman again to perform a biopsy using a hysteroscopy. Also, the thing with the blind biopsy is actually it's much more accurate as a positive test to rule in disease, i.e. if the biopsy shows disease, it is likely that there is disease. However, should the sample not show disease, it's not actually as accurate as confirming that, because it does not sample the whole of the endometrium and you're unable to visualize it. So it's just to bear that in mind. And again, this guideline has acknowledged that. Now, hysteroscopy has a much lower failure rate. However, it's more expensive. And there's quite a bit of bad press within the UK about women having hysteroscopy procedures awake. So it does have other risks associated with it, but also you're able to see and treat, remove polyps directly, etc. I'm move to the next slide. We're going to dwell on this one. It's just that there's very clear guidance to help people who are trying to develop services about who should be seen under what time frame. So what outcomes do we see? Excuse me while I just get this plugged in a minute. Someone was saving electricity and switched my computer off. So one of the things is that we worry about endometrial cancer. But what you can see on my slide here is actually one of the most common causes of unscheduled bleeding, even with a thickened endometrium, is atrophy or inactivity, inactive endometrium. And the way I describe that to patients, and I was told this many years ago, is that when women have stopped bleeding, it's a bit like going into an old house where it hasn't been painted for a while. And then when you move in, which is the start of the HRT, you switch on the heating, and then the paint starts to sort of come away from the walls because it's all getting lively again in the house. And that can happen with HRT. So an inactive endometrium can really start to shed from the lining. And that's why it's thought to be such a popular cause of bleeding. Atrophy, again, is very common, particularly now we call it genitourinary syndrome in the menopause, but the bleeding can be related to that. Polyps always get a bad press. 6% of polyps carry a chance of cancer, and removing them doesn't actually change bleeding patterns, but if we see one, we remove one. And as you can see here, hyperplasia risks do exist, but more so in the sequential HRT women, where they're actively thickening the endometrium and then shedding it. And the endometrial cancer risk is less than 5% in all HRTs, but much less in the continuous combined preparations, compared to the 10% chance in women with PMB. So what can you do to manage this? Again, it's brilliant. It looks at all the options you would get, and it basically gives you the exam answer. So if you do a blind biopsy, which is an endometrial sample, and it's negative, then you can adjust their HRT because there has been some reason why they've bled. And if it continues after 3 months, then recommend a hysteroscopy. If you have done a negative hysteroscopy and a biopsy was also negative, then you can adjust their HRT. And if their bleeding continues after 6 months, they recommend you perform a further ultrasound scan and go back down the algorithm again. If you do a blind biopsy and it's inadequate, and the endometrium was raised on scan, and you kind of hope you only did a biopsy because of that reason, then we would recommend a hysteroscopy within 6 weeks, because there is a chance that you've not sampled the endometrium properly. And if the blind biopsy shows proliferative endometrium, and this is often a bone of contention within sort of colleague groups that I hang out in, some people ignore that. Now, you can ignore proliferative endometrium in women who are using sequential HRT, because of course the endometrium is proliferating, That's why it gets thicker. Then they use the progestogen and they get rid of it. But if you're on continuous combined HRT and you have one major or two minor risk factors, a proliferative endometrium is a cause for concern, and we would recommend doing a hysteroscopy so that you could just exclude there being any hyperplastic changes alongside the proliferation. If they have hyperplasia without atypia, and I hope you're all aware of the guideline that exists from BSG and RCOG, then you just follow the guideline, but we would recommend progestogen. And there are some women who decline to stop their HRT, and of course the wonder treatment for this problem is an LNG IUD, such as the Mirena, you know, to continue to rebiopsy within 6 months to get 2 negative samples. If, however, they have hyperplasia with atypia or cancer, then of course there's a much more increased risk with that. So you can advise them to wean off their HRT. They may say no, but you would also be referring them for onward management with a gynaecologist on a fast-track referral pathway. And these guidelines have never been more directed, and I think it's really helpful to take away some of the ambiguities that have happened between organisations. So the HRT prescribing can be quite challenging. And I think when you're talking to women who come in with unscheduled bleeding, it's worth looking at the compliance. Are they actually taking it? Some women are terribly forgetful. That's part of the menopause. They're not using it correctly. They're not changing patches correctly. They may not have the appropriate dose of progestogen to match the estradiol. They may be using sequential HRT and perhaps should be using continuous combined, because they're older, or they might be using continuous combined HRT but are not truly menopausal, and what they've got is some ovarian function running along in the background, and so therefore having these irregular bleeds, and you might be better advised to switch their formulation. About the lower dose of estrogen, there are some women who actually would benefit merely from reducing the dose of estrogen. Prescribing of HRT requires us to use the minimum dose for the maximum benefit. And some women have merely increased their dose and are not aware actually that while reducing the dose, they may actually still have no vasomotor symptoms, which is fabulous. Lifestyle factors, I cannot highlight those enough, but obviously we know that reducing your BMI, increasing your muscle strength through going to the gym and doing weight training or strength exercises is crucial. Also reduces your risk of cancer. So there's so many benefits to that. Some women have vulval and vaginal symptoms of hypoestrogenism. Or GSM. And actually, again, they've increased their HRT to try and manage those symptoms. Actually, what you could do is lower their systemic HRT and give them appropriate local estrogen to sort out those symptoms. And of course, if they have contraceptive need, then consider the LNG IUD, which just helps with all problems. Other things which some people are not aware of, and many of these are off license, but again are mentioned in the guideline, I cannot teach it all in this session, is considered desogestrel. Desogestrel being a progesterone-only pill, but the addition of this to HRT, particularly in perimenopausal women, can help to reduce some of the bleeding. Using the combined oral contraceptive pill, which contains ethinyl estradiol, so not estradiol, can be used up to the age of 50 and certainly can help with menopausal symptoms. And you may have heard of Clara, which is a combined oral contraceptive that actually uses estradiol, not ethinyl estradiol, alongside a progestogen, and can be really, really useful in the perimenopause where you're giving women estradiol replacement, and it is in a sort of cyclical fashion, between 1 to 2 milligrams of estradiol, but also offers some contraceptive benefits. So, and that often increases compliance because they merely take the tablets in the packet in the correct order. Now, Professor Yasser mentioned that there is a huge drive to go to transdermal HRT, but at the same time, if the use of that is increasing background risk of endometrial cancer, you could consider an oral combined HRT. And certainly I use an oral combined HRT. I'm not quite 60 when I would consider transdermal, but in women who have no other risk factors for VTE or cerebrovascular injury or breast cancer, etc., then I do advocate oral HRT should there be a compliance issue. The new one, which you may or may not be aware of, called Bijuve. Bijuve is a combination of oral estradiol alongside micronized progesterone. And you may or may not be aware, but micronized progesterone has a much better breast side effect. So it's less breast harmful. It has no VTE and no CVA risk attached to it. And so whilst you're giving oral estradiol, and that does have some issues with it, you are still giving micronized progesterone, and that can be helpful. It comes in a 100 milligram progesterone, 1 milligram estradiol, and off license, you can merely double the tablets. And what you're doing is matching the amount of progesterone in that tablet as the estrogen. So you don't have to consider whether to increase the dose. You're then giving 2 milligrams of estradiol alongside 200 milligrams of micronized progesterone. Again, while some people might wish to use transdermal HRT, and they want micronized progesterone, you might actually, again, selecting carefully, recommend they use a combination patch, which can improve compliance. But because of the shortages of these supplies, there can be challenges with that. We mentioned about increasing progesterone dose, and beautifully you've got a table which highlights how to do this depending on the estrogen dose. But also sometimes it's not that. They might be on a low dose estrogen but still bleeding, and you can still increase the progesterone dose without having to increase the estrogen. And for some, you give a combined preparation, but then you add something like a daily norethisterone. And again, the guideline beautifully depicts how to do this, how to review it, what to do should it work, and what to do should it not. Again, I mentioned about switching from a combined combination HRT to a sequential one should the women not be postmenopausal, and that can be very helpful. You can do that for a few months and then switch them back again. Many women do wish to be bleed-free, but not everybody. And a good old favourite again, Professor Yasser mentioned tibolone. Tibolone has an estrogenic, progestogenic, testosterone-like effect. It is low dose. It doesn't always work to manage VMS. Those are most symptoms, and it does have cerebrovascular kind of risk factors. However, it has a much higher amenorrheic rate, and certainly I do use that if we're really struggling with unscheduled bleeding. Coming on the market again, although drospirenone is not a new progestogen, it has been released as a progesterone-only contraceptive as SLIND. We've previously had it as an HRT in Angelique, which is not available within the UK, but it's one that does have a slightly better bleed profile on it. So it may be that off license, we may use drospirenone as an endometrial protector. So in summary, I am well aware that I've talked fast to try to get through my talk for you, but I hope that I've highlighted there is an excellent new guideline. It is very thorough. It is very clear. It talks about the risk factors for cancer, which not everybody was aware of, and how they actually can stratify risk. Most women do not need to come into a hospital under what's called a fast-track 2-week wait referral service, and can be managed under a 6-week referral. It beautifully depicts equivalent doses for estrogen and progestogen. And then I'm not an academic, but this does highlight huge research voids for those that are academically minded. And the guideline has been written in such a way that these research tools, when they've come out and they've got more evidence, we'll be able to put them in so that we can then update it to make it a more thorough evidence-based guideline. So thank you very much. Again, thank you for inviting me. I hope that was understood by everybody, because I know I speak very quickly, and I am available for questions should that be an appropriate time.
Thank you so much, Ms. Tracy, for this valuable presentation. We all got very happy with all this information here and there, and you covered very critical areas in discussing the topic in this scenario. And I think we have a question here. The question said, if the woman is taking regularly progesterone-only pills, can this be used for endometrial protection alongside with using transdermal estrogen?
Off license, absolutely. And I presume you mean desogestrel. If we look at desogestrel, which is a very popular formulation at 75 milligrams a day, what you can do is increase it to 2 tablets a day. Off license people are doing that, but you would need to let the lady know that this is off license. And some of us, when we're prescribing off license, would then do regular ultrasound scans just to kind of cover us medically legally. But yes, and it's a very, very popular regimen to follow.
Yeah, so the next question would be, is the histopathological result of endometrial biopsy is modified by HRT? It means, is the HRT has an impact on the results?
Yes, and it's really important. Women don't need to stop their HRT before they have their biopsy, but it is exceptionally important to write a complete request to the pathologist. So if you're doing an endometrial biopsy, it's very important to let the pathologist know that they're using HRT, what formulation they're using, whether there is an LNG IUD in place, because the progesterone causes some sort of decidualization changes of the endometrium. And if the pathologist is not aware of that, that can upgrade what they report. They may say it's hyperplasia when it isn't. And they can then just highlight this as a progesterone effect. So it's just important to let the pathologist know, but it won't make it officially change the diagnosis. It's just for the pathologist to be aware of that when they're reporting.
Perfect. So the next point is, can you please highlight more the relation between the HRT and cognitive, cognitive behavior of the patient? What is the effect of HRT use in general with stress urinary incontinence, particularly?
Okay. Obviously, that wasn't part of my talk. However, HRT has been shown in women who experience anxiety, particularly anxiety depression in their 40s, with no previous history of a mental health disorder. It has been found to be the first line preparation to help with those symptoms above an SSRI. So that would be the cognitive issue, might be anxiety depression. As for cognition, there is a lot of work and publications about whether it's helpful. There's some studies which have come out looking at dementia risk. And it is thought that HRT, when started or at the time of your perimenopause and not in the postmenopause, may have some benefit. But there's more evidence to come out about whether using combined preparations actually may increase the risk of dementia when started later. So all I'd say is I would be careful about that. The other thing is that a lot of HRT helps with sleep. And when women sleep better, then their cognition the next day is better. And certainly there are some associated effects of that. And also, there is talk, I think we're getting a talk later on about testosterone and its role played in cognition, but certainly HRT is helpful in women getting their brain fog that they talk about, loss of words, and this feeling that they have dementia, which they don't generally at that time. Was there another part to that question? Remember the other
Yeah, definitely. So I know a lot of questions are there, so I'm trying to choose not repeated questions and the targeted ideas regarding different questions. So the next will be how much time the patient should stop HRT maybe prior to the biopsy, endometrial biopsy, to obtain a valid result?
None. As long as the pathologist knows that the woman's using HRT, you do not need to stop it prior to a biopsy. You just need to inform the pathologist what HRT they're using.
Okay, perfect. And 38 years old patient with bilateral oophorectomy on sequential use of every patch with frequent unscheduled bleeding every 2 weeks. Now, what is the best thing could be prescribed for her?
It's whether she would wish to be going for IVF fertility. She's had both ovaries removed. I don't know why. And whether she would be having egg donation fertility, for example. If she is, then the fertility people prefer the women to have some form of cycle. If, however, she has no desire for that, then the Mirena coil would be one of the most useful tools, because that would obviate the need for her to be taking some form of sequential HRT. However, should she not wish to do that, then you just follow the same guideline, because if she's having unscheduled bleeding every 2 weeks and it's been long term, then you would need to do an ultrasound scan and then follow the guideline. And very specifically in that guideline, it states what to do. But if she's a woman who's had both her ovaries removed, I would recommend at least a sort of moderate to high dose form of estradiol, because at 38, she's going to need that. And she might be a woman who'd benefit from testosterone. But some of her bleeding may be from the lower genital tract, because she may be suffering with GSM.
Yeah, and finally, Miss Tracy, can we stop HRT suddenly? I mean, abrupt it suddenly, or we have to do weaning before stop?
You can stop it suddenly. Some women do that, but there is evidence to suggest that by doing that, it increases your cardiac risk. And so what you wouldn't want to do is to do that intentionally. If I'm stopping it, I generally would advise women to wean from it so that they don't suddenly get either that problem or actually a huge escalation of their vasomotor symptoms, anxiety, etc. So we usually wean them down more slowly.
Thank you so much, Miss Tracy, for your presence, your valuable presence. We enjoyed a lot the lecture, the answers, the ideas, and we know that you are very busy, lot of full schedule, but you saved an hour for us. That's why we would like to really thank you for being with us today. We all honored of your presence.
No problem at all. It's been an absolute pleasure.
Okay,
Thank
Muhammad.
you.
Muhammad.
Yes, Professor.
So Miss Tracy, don't forget, I will send you soon an invitation. Just keep this time for us in Egypt. It will be 11th and 12th of December.
Okay.
And we are very happy to meet you here. I'm going to send you all the details as soon as possible, but keep that time for even to see you face to face.
Oh,
and thank you very much for that. Okay.
I've never been to Egypt, but we have many MTIs who've worked in hospital. And obviously I work with Mr. Abdul Fattah, Sharif Abdul Fattah. So that would be amazing. And thank you very much. I am going to go on to joining this meeting, but through my phone as I drive home. I have a 2-hour drive home now, but I really want to listen to the remainder of the talk. So thank you very much. And thank you for listening to me.
Thank you very much for everything you have done for us. Thank you, thank you, thank you. Muhammad.
Thank you, Professor Yasser, and thank you, Ms. Tracy. I will be very happy to introduce now Professor Abu Bakr Nashar. He is one of the most famous professors in Obs and Gynae. He is a professor of Obs and Gynae in Benha University in Egypt, and I think we can just share the presentation if possible. Professor Nashar is with us despite his traveling. He is traveling outside Egypt now, but I think he is online with us. Professor Nashar, good evening. Good evening, sir. Can you hear us? Okay.
He's muted, doctor. Would you like to start his presentation?
Yes, please. We can start the presentation, the voiceover with Dr. Abu Bakr Nashar, and we would like to thank him so much for his presence as well.
Okay.
Bismillah ar-Rahman ar-Rahim. You can get this lecture and more than 700 lecture from my scientific page on Facebook, Abu Bakr Nashar lecture for free download. We will discuss today non-hormonal therapy for menopausal vasomotor symptoms. The source of this lecture is the North American Menopause Society guidelines in 2023. We will address after introduction, and this introduction will include vasomotor symptoms, menopausal hormonal therapy, and the non-hormonal therapy. And then we will go to the non-hormonal for the vasomotor symptoms. And this can be classified into drugs, complementary therapies, lifestyle modification, and stellate ganglion block. Vasomotor symptoms in the form of hot flashes and night sweats are the most common symptoms of menopause. It occurs in up to 80% of menopausal women. It may last for 7 to 9 years, but in about 1/3, it may last for 10 years. Generally arise in the late menopausal transition, but the vasomotor symptoms are worst in the early postmenopausal period. It can be triggered by high temperatures, stress, hot food and drink. This is the stages of reproductive aging workshop plus 10, what's called straw 10 criteria. And as we see here, the start of the vasomotor symptoms in the late menopausal transition. And it is worst in the early postmenopause transition. We can summarize vasomotor symptoms can occur in the premenopausal in about 10 to 25% of women, and in the perimenopausal in 60%. But in the postmenopausal, no flushes are present in about 15 to 25%, and the daily flushing in 15 to 25%. The duration is variable. 1 to 2 years average. This occurs in about 15 to 20%, 5 or more years in 25%. We should put in consideration other causes of vasomotor symptoms. Maybe psychosomatic, maybe due to stress, thyroid disease, subacute or chronic infections, rarely pheochromocytoma, carcinoid, leukemia, and cancer. So we have a differential diagnosis for the vasomotor symptoms in menopause. What is the exact physiology of the vasomotor symptoms? It is not fully understood, but the central thermoregulatory zone becomes narrowed towards the end of the menopause transition, and this will lead to vasodilatation and sweating, which are triggered at a lower temperature. This is the most accepted theory for the vasomotor symptoms. Narrowing of the thermoregulatory zone, that is, it will be sweating at a lower temperature. And this explains where there is no hot flushes and when there is hot flushes with narrowing of the thermoregulatory zone. And there appears to be an association with a low E2 and narrowing of the central thermoregulatory zone. What's about the menopausal hormonal therapy? Menopausal hormonal therapy is the most effective treatment and should be considered in the following condition. Number 1, menopausal women aged younger than 60 years. Number 2, within 2 years of their final menstrual periods. But in all conditions, we should have no contraindication for menopausal hormonal therapy. But the acceptance of the menopausal hormonal therapy was affected markedly by the publication of the WHI study in 2002. And the use of menopausal hormonal therapy decreased markedly, decreased by 80%. Not only this, but the rates of continuation of the MHT have declined largely because of the media and also because the provider advice. So we should consider alternative medical treatment to alleviate the vasomotor symptoms with the marked decrease in the acceptance of the menopausal hormonal therapy. As we mentioned, we should have no contraindication for menopausal hormonal therapy. What are these contraindications? This can be classified into absolute, like unexplained vaginal bleeding, if there is liver disease, blood clotting disorders, or untreated hypertensive. Also, one of the important absolute contraindication of HRT is history of venous thromboembolism, stroke, or myocardial infarction, or if there is a history of estrogen-dependent cancer, like breast cancer, endometrial cancer, and if there is inherited high risk of thromboembolic disease. The relative contraindication of menopausal hormonal therapy is high triglycerides, gallbladder disease, and the elevated risk of breast cancer. In this condition, the menopausal hormonal therapy is contraindicated. What's about the non-hormonal therapy? The vast majority of women will look for non-hormonal or alternative treatment. And it is estimated in the United States, 36% had used some form of alternative therapy within the previous 12 months. And 46% used alternative therapy for menopausal symptoms. The questions to be raised: why alternatives to menopausal hormonal therapy are requested? Number one, if there is contraindication, either absolute contraindication or relative contraindication, or if there is a lack of information about the menopausal hormonal therapy. They believe that menopausal hormonal therapy interfere with nature. The fear of long-term effect of menopausal hormonal therapy. The fear of adverse effects. So this is why the female ask for alternative non-hormonal therapy. Let us go to the recent guidelines of the North American Menopause Society in 2023 regarding the non-hormone therapy of menopause. They stated that there are many options available for treatment of hot flushes, including several non-hormone therapies. And we should have understanding of what is not effective. And in this, so we can avoid the wasted time, the wasted energy, and we can avoid the expenses associated with ineffective or unproven therapy. They classified the non-hormonal therapy into recommended and non-recommended, and also the recommendation according to the level of evidence. Level 1, selective serotonin reuptake inhibitors, SSRI. Level 1, serotonin norepinephrine reuptake inhibitors, SNRI. Gabapentin, and the new drug, the visolinentant, which was approved recently by the WHO, the cognitive behavioral therapy, and the clinical hypnosis. These are the level 1 recommended non-hormonal therapy of the hot flushes. The level 1-2, oxybutynin, level 2-3, weight loss, and stellate ganglion block. So this is the recommended non-hormonal therapy for vasomotor symptoms. The not recommended, level 1, the paced respiration. Level 1-2, supplements, herbal remedies. All of these are not recommended according to the recent guidelines. Level 3, cooling techniques, exercise, soy foods and soy extract, yoga, avoiding triggers. All of these are not recommended because it is not effective. Clonidine, it is level 1 to 3. It is not recommended. Level 3 is the dietary modification, not recommended because it is not effective. So again, as we mentioned, we can classify the non-hormonal into 4 lines of treatment: into drugs, into behavioral therapy, into weight loss, and the stellate ganglion block. So these are the lines of the non-hormonal therapy of the vasomotor symptoms. Let us start by discussing the drugs. And again, we will classify it into recommended and not recommended. The recommended SSRI like fluoxetine, SNRI like venlafaxine, gabapentin, and visolintant, and oxybutynin. The not recommended like the clonidine. Regarding the selective serotonin reuptake inhibitors, SSRI, paroxetine, which was FDA approved in 2015 for management of vasomotor symptoms. We should know what is the dose, what is the add benefit, and what is the side effect. The dose of the paroxetine, 10 to 20 milligram. This is as a baseline improvement. It was found that 50 to 60% improvement, and the paroxetine has best evidence for the vasomotor control symptoms and has a maximal benefit achieved with 10 milligram. But we have an added benefit of paroxetine. It is SSRI, so it is antidepressant, so it will relieve the depression because it is antidepressant effect and improvement of the quality of life. But the adverse effects or the precaution, paroxetine interacts with the enzyme cytochrome B450. So the use of tamoxifen will be less effective when it is used with paroxetine. Fluoxetine, the dose 20 milligram, and the added benefits, again, it is antidepressant, and it will improve the quality of life. But the same precaution with fluoxetine and the paroxetine, it should be avoided in patients taking tamoxifen. Citalopram. Citalopram, the dose is 20 milligram. It has antidepressant effect and it improves the quality of life. But the main advantages of citalopram, much less effect on the enzyme cytochrome, B450. So it can be used with tamoxifen. So citalopram can be used with tamoxifen. What's about the serotonin noradrenaline reuptake inhibitors, SNRI? We have venlafaxine. Venlafaxine, the dose is 36.5 milligram up to 100 milligram. Sustained release preparation is recommended. The benefit, it has antidepressant effect and it will improve the quality of life. But often poorly tolerated at the outset, at the start, it may cause dizziness and other associated SSRI side effects, including sexual dysfunction. So slow titration may be the answer of this side effect. And one of the benefits of the venlafaxine is no interaction with the cytochrome B450, so it is safe and it can be used with tamoxifen. Gabapentin. Gabapentin may be as effective as venlafaxine, but most patients prefer venlafaxine according to one study. Gabapentin, it is a gamma aminobutyric acid analog. It is used for treatment of epilepsy, as we know, and it will reduce the hot flushes at a dose 900 milligram per day. in about 50% of patients. It will improve the quality of life, and it will improve the quality of sleep, and it will reduce pain. But the side effects of the gabapentin is the dry mouth, dizziness, drowsiness, with a very specific dose related component. Patient will find their own level. They titrate or they adjust the dose. One also of the side effect is weight gain, and this is the side effect of the gabapentin, which is used for management of vasomotor symptoms. The new drug is the visolinentant. Visolinentant is a breakthrough and has been approved recently by the FDA in 2023. It reduces hot flushes frequency and severity, and the side effects are negligible, and the dose 45 milligram daily. And the mechanism of action, it is selective neurokinin receptor antagonist. That's why it is targeted non-hormonal management of vasomotor symptoms. And just to remind you about the mechanism of hot flushes, with decrease in the E2 at the menopause, there will be increased signaling at the neurokinin neurons in the thermoregulatory center. Visolinentant is particularly useful, particularly beneficial in survivors of hormone-dependent gynecological cancer. Oxybutynin, it is anticholinergic drugs, as we know. The dose is 2.5 milligram twice daily. It is effective non-hormonal therapy for the moderate to severe vasomotor symptoms. It is associated with a significant improvement of quality of life, and the side effects are acceptable. So this is the first line of treatment. We have, as we mentioned, 4 lines. The drugs. The second line of treatment is complementary therapy. The only recommended are 2, CBT, cognitive behavioral therapy, and the clinical hypnosis. While all of this are not recommended, the herbal, the acupuncture, relaxation, the choreopractice intervention, all of these are not recommended because it is not effective. Let us go just a hint about what's meant by the cognitive behavioral therapy. CBT is a type of talking therapy, focusing on relationship between thoughts, feeling, and behavior. Cognition are our thoughts, while behavior are what we do. CBT help us to identify which thoughts and behaviors might be helpful or unhelpful in our situation. It often involves doing tasks outside the session to help you to learn new skills. CBT is usually focused on the present, although you might also talk about the past. It focuses on the present, although you might also talk about the past. Research has found that CBT can help with issues like anxiety, depression, and trauma. Let us go to the guidelines. And guidelines includes that CBT combines relaxation techniques, sleep hygiene, and learn to take healthy attitude to the menopause balance. What effectiveness of CBT? Decrease in the motor symptom perception, control and reduction in the stress, well-being, and control of sleep problems. The second type of therapy is the clinical hypnosis. Combines power suggestion to encourage positive attention, relaxation technique, reach is mind, the part of mind is relaxed. What the subconscious mind is more open to the health suggestion. What effectiveness? It is effective 10 hot flush reduction. Therapy is effective in teaching the woman hot flush. Third line, so the first was drug, the second was therapy, the third style. What's it? Ended. All of these are not you get trigger. This is effective. Regarding the weight, and that it or the health weight loss associated reduction but dependent age of female and on menopause factor motor earlier transition in the and the age to menopause, but women are or later in both we have a effective vasomotor women earlier transition or non vasomotor is gang is 5 feet is in other still or cycle the zip and bone block the up 10 to block the
ماي الصوت ماله يا ماي. This is totally unprofessional يا ماي.
مين
اللي موجود بيصغر بيسيبه هو 200 شكل. يعني انا مش فاهم انت مش المفروض رجعتي على الكلام ده. طب ازاي الصوت فيه تقطيع؟ انا بتصل بيكي ما بترديش.
الو
Yes.
Okay, so Mohammed, are you there?
Yes, sir. We can because of some technical problems with the presentation of Professor Nashar. I think we need to just refix this problem within few minutes, and we will try to do our best to solve this problem. So I have the honor now to produce Professor Mark Prinkat, the Director of Maternity Services and Health Center, Malta. And Professor Mark as well is a very recognized Obs and Gynae professor worldwide. He's a professor of medical education in University of London, professor of medical education in Medical School Malta, and board governor in Malta, education medical director as well, senior consultant, St. Clair's Medical Services, and the Women Healthcare Facility. So, Mr. Mark, it's our pleasure to be with you today, and the mic is yours.
Right, I'm going to try and get this going, okay?
Yes.
I hope I'm sharing.
Yes, the screen now
Very
is
good.
shared.
Excellent, right. So I enjoyed hearing all my previous speakers, including Professor Nashar, who was giving a very nice presentation. Yes, I do spend my time in the UK quite a lot, but I'm professor here. And currently I'm president of the section of obstetrics and gynecology at the Royal Society of Medicine. And we would only hope to have the numbers that you are having attending our meetings. For reasons of time, I will not speak so much on testosterone, which is a shame because I have a separate lecture on that. But I will concentrate a lot on body identical hormones. Hello? We're all right, aren't we? Okay. So, following the 2001 WHI publication, there was a strong move towards finding alternatives for the treatment of menopause symptoms. And there was a concept of having bioidentical hormones. Now, bioidentical hormones we consider as body identical hormones. There's the same thing. And in the past, we used to call them natural hormones. Now, I'd just like to remind you on this cascade here, and you will see that most sex steroids are derived from cholesterol, which, by the way, is also the cascade, a cascade that goes on to vitamin D here. And since vitamin D is also derived from cholesterol, and since 90% of it is produced in the body itself, there is an argument for considering it as a hormone as opposed to a vitamin. But these are the main hormones in the cascade. I would just like to remind you, there are several metabolites which are active, biologically active metabolites, and do themselves have their own properties. Now you will see the progesterone here is further high up the cascade. We've got the hydroepiandrosterone estate here, the HEA, which can be considered as an androgen, which is also used in menopausal treatment and therapy. Testosterone here, although one would think that testosterone is converted entirely to estradiol, and this is where I'm going to concentrate a bit on testosterone, since androgens is a separate lecture altogether. But anyway, you will see that testosterone is does convert to estradiol here with aromatase activity, but contrary to popular belief, not all testosterone in a woman is converted to estradiol. Estradiol levels are fairly consistent in the follicular phase, but if you were to correct for the units, because we are used to expressing things in different units here, so testosterone is normally expressed as 2 to 4 units or something like that in a woman, whereas estradiol is expressed in picomoles. If you were to express both in picomoles, and I've lost my mouse somewhere, where's my mouse gone? Then you would actually find that a woman in her fertile life has got much more testosterone present than estradiol by a factor of 3 to 1. It's just that males have more, even more, something like a 6-fold increase in testosterone. So testosterone is a very important hormone in women, as is in fact estradiol in men. Men have got as much estradiol as a woman has in her follicular phase, and there are very important functions of estradiol in men, which include bone maintenance and metabolites, estrogen metabolites present very much in the brain. Noradrenaline-like derivatives. I'm trying to find my mouse. There it is. Okay, good. So we have to remember that everything is a balance in life. The testosterone, interestingly, in women keep maintaining its levels for a further 5 years post-menopause. So testosterone is an important hormone. There's a lot of debate about it. We tend to use it. My practice is one that was originally initiated at King's College in London, where I worked for many years. And I'm still in close collaboration with my colleagues, including Ms. Appleyard's, Louise Appleyard's collaborator, Nick Panay, who is a friend of ours. So we are quite strong believers in the use of testosterone. And androgens just give that extra little shine to HRT in that they increase libido, they reduce lethargy, increase concentration, and so are thought to be valuable. Now, this might be disputed, but there were some early papers in the Lancet dating back from 1981, which showed that testosterone in women is valuable, and if women are not on it, they will soon notice. Right. I think I have to move on because it's late in the night. So, well, not for me, because we're obstetricians, and as everybody knows, obstetricians are used to late nights. So, as an introduction, the options for non-hormonal and non-estrogen forms of HRT and treatment for menopausal symptoms have increased post-WHI. Estrogen therapy, however, is the only one that provides a comprehensive multisystemic treatment for the menopause, and the benefits are well known. And replacing estrogen therapy with alternatives is and continues to be a challenge. The transition, well, we've already spoken about this. I just want to remind you that there are short-term and long-term symptoms. Therapy is either targeted or multisystemic. Non-hormonal treatment is targeted. Non-estrogenic treatment very often is targeted, but sometimes there are non-estrogen hormonal-like treatments. And what do we mean? Basically, the short-term symptoms are vasomotor symptoms like hot flushes, irritability, and lack of concentration. There are psychological symptoms such as anxiety, depression, irritability, and the lack of concentration. There are other short-term symptoms like the motivation, the loss of libido here, which fall under the psychological ones, and the dryness ones, the atrophic ones, which are vaginal dryness, vaginal atrophy, urethral syndrome, such as nocturia, dysuria, polyuria, and incontinence. In a pelvis that's previously weakened, the menopause might be the last straw, and increase in intra-abdominal pressure, you can get symptoms of prolapse. 30% of the immune system is thought to be due to sex steroids. So these aches and pains that one gets in the morning are thought to be immune problems and or inflammatory problems, and other overtly immune problems such as asthma and psoriasis can make their first appearance after the menopause. And long-term symptoms are also well known. Osteoporosis was the one that was the earliest known. So women lose something like 30% of their bone mass at around the time of the menopause. But interestingly, bone loss starts in the 40s and then accelerates after 45. Connective tissue, you've got skin, for example, and cartilage was thought to be immune from lack of estrogens, and we now know that this is not so. And you lose and have not only do you lose cartilage, but you actually change molecules in your cartilage. We show this in vertebral discs, for example, after the menopause. So you get a stiffer type of, for example, vertebral disc. Christensen had shown this in hinge joints as well. Cardiovascular infarcts catch up very quickly with those of men after the 50s. And unfortunately, when they do happen, they tend to be to have a higher mortality than those in men, as do cardiovascular accidents and stroke, and these tend to be thrombotic strokes as opposed to atherosclerotic ones in men. And Alzheimer's is commoner in women by a factor of 7 to 1. Now, there are a number of recommendations that have come out very recently, and one of them is the British Menopause Society's one, and the Women's Health Concern. And then the BMS actually combined a statement with the IMS, EMAS, European Menopause Society, the ERC-RCOG, and the American Menopause Society. They issued a joint statement, a very important one, at around the same time, about 2020. and they all more or less say the same thing. And this was a response to the updated data that came out from WHI to do a sort of rehash of the old milliwomen studies, which all is false, and to the EMEA recommendations, which always needed to be updated. And there were also always these cautionary statements from European bodies or from international bodies, which were, however, meta-analysis based. They weren't properly clinically based. CHFBC. Now, our contention was that the WHI was, in fact, from day one, misrepresented. And this was admitted as such by later installments that came out. And we'll talk about that later. So, what is this concept of bioidentical hormones that we are talking about right now, which is the modern way? Because at the end of the day, we have not remained static. Things have moved since 2001, since WHI. And when we talk about tailored treatment, we are talking mostly about bioidentical hormones. As you've heard the previous speakers talk about, they were all talking about, for example, estradiol, not ethinyl estradiol. And they were talking about a progesterone, either natural progesterone or something like dydrogesterone, which is very close to natural progesterone. Now, natural progesterone is either micronized or vaginal, if you like, but that is the real bioidentical hormone. And this is a concept which has to be appreciated. These hormones that we're talking about resemble the main hormones that are produced in a human being, in a woman. But they're all derived from plants in the pharmaceutical industry. They're just they're from plant origin, and they're modified to resemble the principal estrogen or progesterone found in women. So there's no such thing as a body identical hormone derived from a human being, for example, because they're all exactly the same, but they're modified. And the compounded version, now to make an allowance for the compounded version that has been around, has been marketed, and these are regarded as natural receptacles. And as natural receptacles, they are therefore outside the FDA remit, and they are compounded. They're not regulated, okay? So we have to be a bit aware about this distinction that we make between compounded bioidentical hormones and regulated bioidentical hormones. Now, this is, or body identical hormones, this is not new. We have been calling these hormones natural hormones for a very long time. And I've just lost my, here we go again. Okay, so now what about conjugated equine estrogens? Are these natural? Well, it's very interesting because these have been a very successful group of HRT. Nobody can doubt that Premarin was very successful. And prior to pregnant MERS estrogen, conjugated estrogens, we had pregnant human conjugated estrogens. And these are the estrogens that are derived from urine, from a biological source. In this case, a pregnant male produces vast amounts, and it's easy to commercialize this. And we have had excellent results with conjugated equine estrogens. And this was the main estrogen that was used in WHI, for example. 17-beta estradiol is the one that's commonly used nowadays, commonly known as E2. But in the contraceptive pill, it is ethinyl estradiol that's the main hormone that is used. And this is not regarded as a natural hormone. Nowadays, there are 17-beta estradiol oral contraceptive pills, such as Clara or Zoli, that are around, which are excellent for the menopausal transition. So the compounded body identical hormone replacement therapy is compounded in response to salivary sample. Now, I spent years in this type of research looking at salivary content of hormone content in women's saliva, and we know that this fluctuates quite a lot. Actually, it fluctuates from hour to hour, and it's not a reliable index of the of a woman's constant sex steroid or estradiol content. So you might be compounding a bioidentical hormone in response to saliva, but it will be quite different if the saliva sample was taken a couple of hours later, for example. So these are not constant. They fluctuate from day to day, and also from woman to woman. So the advantage of using regulatory body identical hormone replacement is that we've got a constant dose These have been subjected to studies such as FDA or EMEA studies. They're easily available and cheap. One has to say that post HRT is actually cheap. And they're highly effective in resolving short-term symptoms of the menopause. And they're also broken into various metabolites, which are biologically useful. So why make a simple solution complicated and expensive? There's no need to. So we will be talking about regulated bioidentical hormones. So here are some examples of bioidentical hormones. There are the gels, which we've heard a lot about. There's a lot of gels around, such as estrogel, for example. We've been, and this is actually not new. I had research on this 40 years ago using a French product, and we were looking at skin samples and looking at skin collagen. Patches are also very useful. However, I have to caution people using these in hot climates because they tend to cause rashes. They tend to remove them before you go swimming or wherever, and they might be inconvenient. But gels have none of these problems. There's still a big role for oral preparations. Most of the complications with oral preparations are theoretical, but they are convenient to use, they're cheap, and they've got a higher rate of compliance. Compliance is a big problem with HRT because most people stop taking HRT after about 2 years. We've got this Monjuvi, which we've just heard about. We've got the estradiol 1 milligram and progesterone 100 milligram preparation. You can also use this as a form of a gel. The progesterone here is micronized progesterone. This is an oral preparation. It's a combined continuous preparation. Vaginal tablets are available over the counter in the UK. There's 10 micrograms of vaginal tablets preparations. There's also estradiol 1, which is also, if you remember, the cascade and natural estrogens. We have hormone implants available to us. Not many countries have estradiol implants, but they are a very effective form of HRT. And we get ours from the States. And they are on a patient, they're prescribed on a patient-named basis, although there's over a 60-year experience using these implants. They were originally used by Professor Bob Greenblatt, one of the pioneers in HRT. Now, the new boy on the block is estetrol here, and I remember being in the brainstorming session when this was launched, when this was being taught about 20 years ago. It was actually an old hormone. It's present only in the fetus, the human fetus, or in primate fetuses, I should say, and it disappears after the birth of the baby. So we believe it's got a role. My own personal feeling is that it's present to give all the benefits of an estrogen to a fetus, whilst at the same time blocking the effects of estradiol. Because if a baby is exposed to the high dose of estradiol present in a woman, there might be some unwanted feminizing effects. Estradiol does not do this for some reason or other. It sort of resembles a SERMs, but it does have the same role as estrogens on the development of the brain. And it's the reason why it's present in primates is thought to be at least something to do with brain development as well. Dihydroepiandrosterone, DHEA, is here. And this is also a natural hormone. Testosterone implants or gels, which are also used in combination with estrogen. You should not use testosterone on its own, please, because you'll get unwanted androgenic side effects. So if you use testosterone, either implants or gels, and there is androgel available from the same company, for example, it produces estrogel, and these are rubbed in, then you will find that you might get an additional beneficial response as regards to concentration, brain fog, libido, and also vaginal atrophy. I'm sorry, I keep on losing my mouse. There's progesterone here. Now, progesterone, really, we talk about micronized progesterone. And the reason why we talk about micronized progesterone because if you use the oral route for natural progesterone, then progesterone is broken down in the stomach. If you use a micronized form, 20% at least of it will be biologically available. Vaginal, of course, we know that we use quite a lot of it in infertility, for example, and you can use it as a form of HRT, and vaginal progesterone. Now, as an aside, there is a cousin, a stereoisomer, that is very similar to micronized progesterone, which is dydrogesterone, popularly known as Dufaston. But I've left it out. So risks we've heard about in previous lectures. There's endometrial cancer. As you said, out only without progesterone can be used in those without a uterus. But if there is a uterus, you have to use a progesterone. There are side effects like thrombotic events, example, deep vein thrombosis, which are commoner in women on HRT, but not as common as women who are on the pill, for example. But I have to say, as an aside, that the menopause itself is a thrombophilic event, makes you more prone to DVT. So we've got to separate the chaff from the weeds. CVA strokes, breast cancer is an open question, which we will discuss in a minute. This is the real one, gallbladder and cholecystitis. This seems to be consistent. There are some studies like Kronos and Elite and Epic, which we've heard of, which do actually show that you can prevent many conditions using estrogens. It's interesting that there's been a study that is not peer-reviewed yet, but has nevertheless been reported in the New Scientist, which shows that there are 4 drugs that increase longevity, and by far the one that's way ahead of the others is HRT, which and this is from a huge database in the UK that has been studied. The others are naproxen, statins, and interestingly enough, Viagra, sildenafil citrate. Metformin, sadly, does not feature in this list. I'm trying to find a paper. I can't find it anyway, but it will be coming out very shortly, and it's really literally hot off the press. It seems to be a very reliable, very strong study correlating longevity with these drugs, but also try to explain the physiology, how this happens. Got to be, as a caution, I would say that, as we say, correlation does not imply causation, but it's a very big study by Oviedo et al., and I'd like you to keep an eye out for it. Now, what's our evidence on thrombosis? And is all HRT the same? Well, this is the best study that we've got currently from Vinogradova, from Cambridge, our new epidemiologists now, who I think have taken over from, sorry, these are from Nottingham, and they've taken over from the Oxford group. And you can see that here, there are differences. Not all HRT is the same. So you can see if you use estrogen only, HRT, or the oral, by oral route, you'll find a slight increase in the incidence of thrombosis. Medroxyprogesterone we don't like using anymore, not particularly as a result of the WHI study, and norgestrel combined with conjugated equine estrogen, you get slightly higher increased risk of thrombosis. And there are differences with the different progestogens that are used. Dydrogesterone here, which, as I explained earlier, is the closest one to progesterone, being the least. If you use transdermal, however, there's no risk at all of an increased DVT risk here. Tibolone does very well as well. Raloxifene SERMs, which is also a sort of hormonal type of HRT, which we use for osteoporosis. Raloxifene is a SERMs, as you know, closely related to tamoxifen, and there is a slightly increased risk of thrombosis. We know that. Oops. Let's see if I can go back. Yeah. Just had a cat run over my computer. Right. Here you can see different doses of HRT. And when it's estrogen only, HRT, we always do well. And this is the natural estradiol here. 1 milligram and 2 milligrams, no different. And combined oral further down as we go. And once again, transdermal on its own without a progestogen. So these are with a progestogen. Dydrogesterone always comes out as the best. Estradiol here on its own, estrogen only, gives us no increased risk at all. And here it is written in a different format. And we can always see that the best ones are transdermal HRT when it comes to thrombosis. CEE with dydrogesterone, I mean, the increase is very small. The worst one is medroxyprogesterone estate. And this is, unfortunately, the preparation that was used in the WHI study, where not only did we have now it's realized not such a high increase in breast cancer rate, but whatever it was the MPA, because the CE on its own gave us a lower breast cancer rate than placebo. We find it's got a higher thrombosis risk as well. But if you look at different gestogens, then we soon realize that it's a gestogen problem, and we'll see this later on as well. Estrogens on their own, transdermally, no higher risk of thrombosis at all compared to placebo. So contraindications to treatment: if there's an elevated risk of clotting, if there is a hereditary thrombophilia, for example, one should be cautious, or one could use patches only or gel only. If there is a higher risk of stroke, somebody has had a previous thrombotic episode or CVA. Of course, if it's been as a result of a road traffic accident or whatever, this is a relative contraindication. And estrogen-sensitive breast cancer, uterine cancer, unless it's a very early form, and in discussion with the oncologists, one can still use estrogens. This is particularly a problem in women who are on aromatase inhibitors, who've had breast cancers, are on aromatase inhibitors, have had a very early breast cancer, and if they've had a hysterectomy in particular, they get very painful vaginal dryness and vaginal atrophy. So in these cases, very often one is allowed to use vaginal estrogens. But there is debate about this, and there seems to be no increased incidence in breast cancer recurrence if low-dose estrogens are used. And liver disease, because the liver, as you know, even with transdermal preparations, is still impacted by sex steroids. But anyway, once again, this is a relative contraindication. So if you look at WHI, which was the biggest challenge, you'll find that this wasn't just a study on breast cancer or HRT. It was a nutrition study. It was a well-being study of various sorts. It was a cardiovascular study. And the main interest here was to see if you could prevent cardiovascular disease in women using HRT. So these women tend to be older women in their 60s on average, so that they could be properly placebo-controlled. And one of the contraindications was women having hot flushes. Nevertheless, we did have a subgroup of women who were in their 50s, but these weren't your typical women. They were obese, they were in their 60s. They were not the women we normally treat with HRT, who tend to be younger. So there were 60,608 women with an intact uterus on CE and placebo versus placebo, and women with no uterus were on CE alone. Enrollment was from 93 to 98. And this is the study it was an excellent study, but was misinterpreted. Okay, it's easy now to say in retrospect, we used the wrong gestogen, but that's what was available and popular in those days. So there we go. But I mean, many of us were unhappy with MPA from a metabolic point of view. But anyway, so you can see here straight away in the first paper that was published in 2001, we had a 1.44, we had a slightly higher incidence. So I was just skip the early papers actually and go directly to the 18-year cumulative follow-up. Because if you do see all the early papers, you will see straight away these results recurring. So in the early study, we already had the CEE alone showing us a reduced incidence of breast cancer, not a higher incidence, and a non-significant, slightly higher incidence of a few cases only of extra breast cancer cases, mostly because in that particular year, the 5th year, the placebo group dipped for some inexplicable reasons. The incidence of breast cancer in the placebo group dipped. But anyway, be it as it may, this was not a surprise because CEE in the past had been used as a cytotoxic agent in women with recurrent breast cancer. And this was particularly effective, especially effective in women who had estrogen receptor positive breast cancer. So if somebody has an estrogen receptor breast cancer, it would be quite wrong to say that the breast cancer was caused by estrogen because it is an estrogen receptor breast cancer. It just happens to be 80% of all breast cancers. And we know that cells take about 15 years to develop. Like somebody said the other week, if you water the lawn, weeds will grow, but the water does not create the weed. So the weed is already there. And it might come up to the surface. And the idea was that if it comes up to the surface quicker, it's recognized quicker and you can remove it faster. But this finding that after 7 years of HRT, because that's how long they had been on TE, kept on going for a bit further, than the CE plus MPA, because this group were stopped after 5 years. This group kept on going for another 2 years, and then was stopped, not because of breast cancer incidence, it was stopped because there was no advantage in cardiovascular outcome. But looking at this lot, 18 years later, still showed that there was a highly significant decrease in estrogen receptor breast cancers. And this figure here, a 45% reduction rate, kept on being shown. And also, it's very similar to the reduction rate you get, for example, in the prophylactic studies that were carried out for tamoxifen and for aromatase inhibitors. And it's the sort of figure that came out as well, the core and more studies for raloxifene. So it's very similar. It is possible to reduce the incidence of breast cancer using pharmacology. So the ABIS-1 and the ABIS-2 studies, ABIS-1 was for tamoxifen, showed that if you selected your high-risk patients, you could, with tamoxifen alone, for example, reduce the incidence of breast cancer rates by about 40-45%. CE alone, in an uncontrolled group of patients, showed the same reduction. But to be fair, these were obese 65-year-olds, so I wouldn't say they were high risk exactly, but they weren't low risk either. Okay, so looking at the all-cause mortality rate, after 18 years of follow-up, there was no difference in mortality rate in the whole group, in both groups. So that's about over 32,000 patients. There was, if you look at your breast cancer mortality straight away, a reduction in the estrogen-only group. So I'm sorry for this busy slide. This is a direct reproduction from the Manson slide. And a slight increase in those who had been on gestagen. So the answer is change your gestagen. Estrogen only, look at this, a significant lowering of dose. And here you can see that not much of a difference. There is another one down here which looks at Alzheimer's. Now, as Louise Appleby said earlier, there's been a BMJ study now that has suggested that there's an increase in dementia rate in women who've been exposed to HRT. But, you know, once again, correlation is not causation. The numbers were small, and it's very difficult to find any logical explanation as to why estrogens alone, estrogens which are such important metabolites of the brain that are produced in the brain independently, anyway, through its own aromatization, should be deleterious to the brain. In this study here, it was shown that the dementia rates were lower, mortality from dementia rates were actually lower, and significantly lower, significantly so. Look at that, 0.01. And if you were now to divide your groups into 10-year cohorts, then the window of opportunity that we talk about becomes obvious. And this is using oral conjugated equine estrogens, mind you. So very, very basic estrogens. And you will see that the all-cause mortality was less in every single group when you started your patients on treatment between the age of 50 and 59. And this is why this current study is so interesting that's coming out. This shows that from a longevity point of view, HRT is way ahead of any other therapeutic maneuver that one might wish to consider. If you start your HRT between 60 and 69, then there's really no huge advantage other than the overall mortality. You can see these groups of cardiovascular mortality here, cancer mortality, whatever. Cardiovascular mortality in the 50-59 group is less 18 years later. That means when they're hitting their 70s, okay? And cancer mortality here is better. I can see this advantage. And you can even start your HRT in your 70s here, and you're not going to be, apart from your quality of life, which will improve, you are not going to be at a disadvantage from your other mortality indices, okay? In some cases, like cardiovascular mortality, even starting that late, you are at an advantage. So this is WHI saying this 18 years later. Now, having gone through every single WHI paper that came out from 2001, you'll find that this trend in no different mortality is actually present in every single paper. So unfortunately, this was not realized maybe, and there's no difference. It's just that the numbers got bigger as patients get older, you know, and patients then did die, because that is quite a significant endpoint. But it was no different, you know. The very first paper showed no different mortality in every single group, whether they were CEE plus MPA or CEE alone or placebo. 20 years follow-up, Jablowski of WHI, similar results, won't go into them. Now, what about estradiol alone? This big French study called the Fourier study, it did show, once again, 100,000 women, quite a lot of women by European standards for sure. And you can see that estradiol alone, no increased risk of breast cancer, is not significant. You remember that we mentioned earlier from the thrombosis study, there was no micronized progesterone in the UK data because micronized progesterone has only relatively recently become very popular. Although I did have it available many years ago, it was not regarded as being practical for use in the clinical environment because it was regarded as being a weak progesterone. But the French do use it quite a bit. And you see that there's no increased risk at all in breast cancer rates, and dydrogesterone here, which is Dufaston, the risk is very, very small. So the message from the Fourier study is that that estrogens alone are very safe, and that you've got to be careful on which estrogen to choose. And these are patients who've been on HRT for quite a long time. Moving on, and here the Fourier study is depicted in a different way, and you see the estradiol and micronized progesterone with no difference really from placebos, and on slight teeny-weeny, non-significant difference if you're using dydrogesterone, synthetic progestogens of various sorts, MPA and nortriestrone and progesterone together, and they're the ones who give you a slight increase. I won't go through this slide because for reasons of time, but it's more or less the same. It's an extension of the study, but I will concentrate on Vinogradova. Once again, these have got access to huge databases in the UK of patients. They're called nested groups of patients, nested case control studies. They're very clever how they analyze this data. And the aim was to assess the incidence of breast cancer in women who've been on different types and durations of HRT. And there are nested case control studies identified women between the age of 50 and 59, and once again, huge groups of women, 98,000 here, were diagnosed with breast cancer, and they worked backwards this time. Women on breast cancer, and they were seeing whether they had ever been on HRT. So in a way, it's working backwards, and this is the same studies, the same results were found as the Fourier group. So that estradiol had no increase at all. All HRT had a very slight increase. And I've got to remind you that when we talk about risk ratios here, you've got to see the numbers. So let me give just a quick example. 2 out of 10 and 3 out of 10. So 3 out of 10 is a 50% increase. But 2 out of 1,000 and 3 out of 1,000 is still a 50% increase. But 2 out of 1,000 and 3 out of 1,000 is far less significant than 2 or 3 out of 10. And 2 or 3 out of 10 or 100,000 is still 50% increase, but the difference between 2 and 3 out of 100,000 is not very significant. So you've got to look at the numbers when you're discussing risk ratios as well. And you find the numbers are actually very small and they're not significant, okay? Because we can't say that HRT actually causes something if there's a small difference between one group and another. Okay, but the good news, the interesting news from Vinogradova is that even if you were on treatment for 5 years here, and there would be with mendroxyprogesterone estate, once again, the biggest increases in levonorgestrel, the biggest increases in from breast cancer. This went back to normal very, very quickly after stopping HRT. Now we know that most people only take HRT for about 2 years anyway. So the risk of taking HRT for 2 years long term is, according to Vinogradova, 0, or as near to 0 as possible. So even if you take it here for 5 years, then once you stop taking your HRT, you've got benefits which are long-lasting, as you can see from the WHI 18-year-old and 20-year follow-ups, but the risks of an increase in breast cancer very quickly go back to normal. So I think this study is very, very important. Okay, so what about progesterone? Well, we needed to prevent endometrial hyperplasia. We've heard previous speakers, Dr. Appleby telling us that we need to often be aware of endometrial hyperplasia and a typical hyperplasia and endometrial cancer and so on. This was the first bust in HRT. HRT was very, very popular in the 60s, but then it was suddenly stopped because there was a high incidence of endometrial cancer, albeit stage 1 endometrial cancer. But still, it was a nice thing. This was solved by the use of gestogens, solved by people like Studd, Whitehead, and Greenblatt. But there are side effects from gestogens, which even then were realized as being unpleasant, like breast tenderness, premenstrual tension, and then we later realized problems with possibly with breast. Yeah, but if there's no uterus, you don't need to take a progestogen. Most people would say, therefore, there's no problem. A small caveat if you have endometriosis, but even then, we don't think it's that necessary. So it's nice to be able to take estrogen on its own, and you've got all the benefits without the pain. Now, here I will stop a bit and say that sometimes the use of androgens with an estrogen also obviates the need to have a progestogen, but this is still work in progress. Okay, so there are estrogen testosterone products where there is no need to have an additional progestogen. Yeah, but we just have to be a bit cautious about that.
Mark, I'm sorry to interrupt you because we're running actually out of time.
Okay, I'm ready. This is my last slide.
Okay.
Okay. So Alzheimer's is here. Okay. I know everybody has been late.
I'm sorry for that. I'm sorry for that.
You can see, and I'm the last one, so I inherited everyone. So this is a normal brain, an Alzheimer's brain. So you've been subjected to a long decline in brain size before you actually get your dementia. I'll move on because of lack of time. This is definitely my last slide. For osteoporosis, I have to say that this is an oral preparation known as Christensen's crocodile. Early on, we have an increase in bone mass. After 2 years, it was switched to placebo and to oral. To activation, and you can see that we can get a slight increase in bone mass and a decline once you stop, whereas this group here was on placebo. There's a decline once they stopped. After 2 years, they got an active agent again, and this group kept on placebo. And what's interesting here is that it was the first time that was shown that you could actually increase your bone mass with HRT as opposed to stopping your decline. So take home message: individualization of therapy is important. You've got to discuss, you've got to assess your patient, you've got to take a clinical history. It's got to be appropriate to use the women. There's a window of opportunity. So individualization of therapy is, do we need patches? Is she reliable? Can we use tablets instead? Are tablets easier to use? Yeah. Here is a depot preparation like an implant, and so on and so forth. Prices, cost-wise, cost effectiveness. Other potential uses of HRT in multisystemic pathologies. Should we be using HRT as the most effective agent to prevent osteoporosis, for example, prevent cardiovascular disease if used in the appropriate window? And we have to reassure people, have got to have confidence that it's safe, beneficial when used properly, like every other form of medication. Okay, I'd like to dedicate this lecture to Professor Studd here, late Professor Studd, my peer, mentor, and friend. And this is Professor Stevenson, who's still very much alive. And there's myself at the Royal Society of Medicine. And this is an alternative form of HRT known as a menopause cake with lots of phytoestrogens in it, and lots of lovely goodies. And 1 slice a day keeps your flushes away. That's what they say. Great. Thank you very much. Okay. Sorry for running a bit late.
Thank you so much, Professor Mark, for this very rich presentation indeed. And again, we have some questions. So we will ask you please to answer these questions. The first one is the VTE is caused by estrogen, or it's mainly depending on generation of progesterone?
Well, as you saw from Vinogradova's data, it is not a natural bioidentical, body-identical estrogen that causes it, but it is the gestogen that does it, that increases your risk. However, this is very dose-dependent. Okay, obviously, in the past, when very high doses of estrogen, particularly ethinyl estradiol, was used, this increased the risk of thrombosis. So once again, it depends on what we are talking about. But in normal doses of HRT, as it is used, the body identical estrogen does not seem to be increasing your thrombotic risk. While gestogens,
yeah,
sorry, gestogens such as norepinephrine, for example, and medroxyprogesterone acetate are more prone to cause thrombosis.
Yes, thank you. So is it okay to use the HRT safely with migraine if it's without aura?
Well, I mean, as one of the previous speakers have said, migraine is not really related to HRT. Interestingly enough, migraine in women sometimes there are menstrual migraines, and as a result of a change, a sudden shift in estrogen, you get vasospasm. There are vasospasm reasons why people get migraine. So in that case, using a low dose of natural estrogen, such as a gel, might actually relieve your migraines, not cause them. You know, but if there's any evidence of thrombosis, you have to be cautious. But the word, the vasospastic
Perfect. Thank you so much.
Yeah. Okay.
Yeah, thank you so much, Professor Mark, for your valuable presence. We enjoyed a lot the very rich presentation, and we appreciate your time and effort in this presentation. All of us, thank you from heart. And according to multiple requests of our attendees, we will be very happy to announce or to continue the presentation of Dr. Abu Bakr Nashar.
All right.
And
Yes.
after fixing the problem, the technical problem related to the presentation. So please, we can move with the presentation of Professor Nashar, as we just have a very limited time since this session will be closed. Thank you.
Thank you.
Avoiding triggers, all of these are not effective. Regarding the weight loss, it should be done early. And it was found that in overweight or obese healthy women, the weight loss is associated with reduction of the vasomotor symptoms. But this is dependent on the age of the female and dependent on the menopausal stage. Obesity is a risk factor for vasomotor symptom earlier in the transition, just to say in the perimenopause and the early postmenopause, but not when women are older or later in the transition. Weight loss may have a greater effect in reducing the vasomotor symptoms when women are earlier in transition. Lastly, the fourth line of the non-hormonal therapy of the vasomotor symptoms is stellate ganglion block. Anesthetic is, which is 0.5 bupivacaine, is injected under ultrasound into the stellate ganglion at the cervical 6 or cervical 7 vertebral level. The mechanism of action is not well known, but it was found that with the stellate ganglion block, there is a reduction of the vasomotor symptoms in 50 up to 90%. 6 weeks to several months after block. It will last for 6 weeks up to several months. So we can conclude that the stellate ganglion block is a treatment option for the vasomotor symptoms in both the mid-life woman and those with breast cancer. This table illustrates the non-hormonal oral treatment for the vasomotor symptoms regarding the drug type, the dose range, frequency, the vasomotor reduction or the efficacy, and the side effect. To come to the conclusion, menopausal hormonal therapy remains the most effective treatment for vasomotor symptoms and should be considered in menopausal women aged younger than 60 years. It should be considered within 10 years of their final menstrual periods. It should be considered when there is no contraindication. For women who are not candidate for menopausal hormonal therapy, either because there is a contraindication or personal preference, non-hormonal treatment options that are supported by evidence. It should be supported by evidence. And we have 4 lines of treatment. Drugs like SSRI, fluoxetine, SNRI like venlafaxine, gabapentin, fezolinetant, and oxybutynin. The second line of treatment is behavioral therapy, CBT or clinical hypnosis, weight loss, and lastly, stellate ganglion.
Okay, I think Professor Nashar is finished. Just finished. Is Professor Abu Bakr there? May?
He's trying to join again, doctor.
Okay, that's fine. So tell Professor Abu Bakr Nashar, Muhammad, would you mind to prepare some question for Professor Abu Bakr? And let me to thank very much Professor Mark Branket for his effort. Thank you very much. And I think we pressed you hard. Professor Salam told me that you used to sleep a little bit earlier. So I'm very, 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 very sorry. But when we have someone like you, I think we are doing our best to keep him with us as much as we can. So we're
No problem.
we are appreciating very much for your effort and being late till now to join our presentation and our session. Thank you very much for your kind care. And we if you don't mind, we are going to send you an invitation, despite the fact that Professor Salam told me that you have some problems with your legs, like everyone nowadays. But if you have the chance to come, it will be great to
No,
see you.
it's virtually gone now. It's okay.
That's fine.
In 2 to 3 weeks,
why it's
I'll
gone?
be fine.
It's gone because you are coming to Egypt.
Yes.
So
Thank you.
Where
Yes.
Yes.
Thank God it's gone. You know, I mean,
that's
a couple
great.
of weeks.
I
took a bit of skin off. So anyway,
that's great.
I'm going to
Congratulations.
ISG. There's the ISG conference in Florence, 7 to 12.
Yes.
So hopefully I'll
great.
see you there. I'll see some of you.
Okay, but everything is right now. So
yes, but I cannot travel far. You know, for now. You know, but by December, inshallah, by December I'll be fine.
Thank you very much, and we are appreciating your support, and thank you.
Yes.
And again, apology for being late.
No, it's no problem.
Thank you. May, where is Professor Abu Bakr?
He doesn't have a net, unfortunately.
I'm sorry?
He doesn't have internet connection.
He has no internet connection. So
Professor Nashar actually is outside Egypt for all our colleagues. Yes. So he's as usual in a scientific mission.
That's right.
The word,
and I feel that his session was great actually, because actually what's nice that he presented the medication in the trade name and the scientific names as well, and show the boxes how it looks like and its replacement. Because do you know, on counseling, Muhammad, some of menopausal women don't prefer to have any type of hormones. So they would prefer to have any medication apart from hormone. That's why it was a very effective session. Yes.
Yeah, we still have this ideas in our community among different kinds of women.
Yes.
They are so much afraid from cancers if they are receiving any hormonal treatments. And we as well, the non-hormonal treatments will be very beneficial for comorbidities like hypertension, uncontrolled diabetes, and the DVT problems, or even strong history like PMI, high PMI, or positive history. So it's essentially for all candidates and all our colleagues to know very well the alternatives, rather than just giving the patient hormone replacement therapy, despite it's the first line management, but alternatives are critically important to be known.
That's fine. So May, would you mind to ask Professor Nashar if he can get any internet connection within 2 minutes or something like that, or it will be difficult? If it's difficult, so just
actually, I cannot reach him neither on his personal.
You cannot. Okay, no problem at all. So Muhammad, do you have any question to Professor Nashar? Try to answer till we meet him.
Actually, on my list, I have no comments on the Q&A questions. Thanks for all affirmative. Yeah, people are very happy. Thank you all. Actually, there is no specific question regarding this presentation to be answered.
And I think we can do another thing as a community. service as well. I think Mohammed and Jihan, it will be great to repeat what we recorded, actually, to repeat this meeting in another time and send the content and the password for everyone. So if anyone missed part of this meeting, he can catch it again. And we might ask Professor Nashar and our colleagues as well to join the meeting again to rediscuss it in another time. Okay,
it's a great idea, sir, because many people also could not attend this session or meeting because of other commitments, and they were very happy to join another one to the same topic. So it's a great idea. We will do.
That's fine.
Yeah,
that's
I'm
fine.
fine.
So
I'm fine. I'm happy with that.
okay, that's fine.
Yes,
So
Professor Mark, thank you.
So in the name of the IRC, the International Representative Committee of the Royal College in Egypt, I would like just to thank you all sharing us our first community-based activity, and we promise you that we are going to conduct more and more and more community service to support everyone in the world, okay, especially in Egypt. I would like just to send congratulations and thanks letters for Ms. Tracy. Thank you very much with a great support, and I hope that she by this time should be home safely. So thank you, Tracy, very much. As well, Professor Mark, thank you very much. And again, apology for keeping you for late time.
No, really. I have no problems. I have problems sleeping, not sleeping.
Oh,
I don't know what Hassan said. Give him my regards.
Will do. And lastly, Professor Nashar, who is, I'm considering him as our senior, actually, and the Egyptian representative of the scientific-based programs all over the world. So thank you, Professor Nashar, very much for cooperation and being here with us, and looking forward to hear from you, your feedback, and if you wanted to improve any points, let us know to support you in the future. Thank you very much, and have a nice night. Thank you, Jihan, our secretary, for your effort and coordination of this meeting. Thank you very much, Muhammad, for being with us all the time. And as usual, you are one of the best person I have ever met in my life. Actually, you are doing our best to raise the standard of practice in everything. And as
Thank
well,
you.
Thank you very much.
Thank you so much, my dearest professor. Thank you for support, and thank you for the opportunity given to me to be with you in this session. Thank you.
You're welcome. Thank you, Mai, very much, coordinator and the company who just arranged everything, and looking forward to have more cooperation with the whole team. Thank you very much, and have a nice night. Bye.
Bye. Bye. Bye. Thank you.